be what he ends up, those will be interviewed, submitted as evidence.
Okay.
Anything else?
The other thing, I'm sorry.
Yeah. Still short? We're ready whenever you are. Yeah.
This is for the Vasopressors. And which one is this? Yeah, the place is done. See the charges?
Yes.
This was a right here.
They're happy, happy.
Judge, Dr. Ely's going to run the rest of them real quick.
Ed, hurry.
Does he know where it is?
You can pull it around there. I'm sorry. Cleaning crew. You can be seated. Ladies and gentlemen, of the jury, I hope you had a great weekend. We're going to continue on with the testimony. Ms. Sawyer, call your next witness.
Thank you, Your Honor. State call Dr. Wesley Ely to the stand.
Doc, I need you to raise your right hand. You solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God?
I do.
You're going to make yourself comfortable. You've got an aerial mic there in front of you. Okay, I need you to state your name and spell it for my court reporter so she can get used to your diction.
Sure. My name is Dr. Wes Ely, W-E-S-E-L-Y.
Can you hear that, Sam? Okay.
And Your Honor, if we can have the screen down, we're going to need that with them at some point.
Okay. I would have normally put it down earlier, but
I know. Thank you, Your Honor.
what are you going to run it off of? The projector?
Yeah, overhead, I'll be running it off of. Thank you. Dr. Ely, where are you employed?
Vanderbilt University and the Veterans Affairs Administration Hospital, which are both in Nashville, Tennessee.
And what is your position with them?
I'm a professor of medicine at Vanderbilt University, and I direct a research center there called the Critical Illness, Brain Dysfunction, and Survivorship Center, CIBS, SIBS Center. And I, at those two hospitals, teach medical residents, interns, and students, and take care of patients in the medical and surgical intensive care units.
And are you a licensed physician in Tennessee?
Yes, I've been licensed to practice in Tennessee since 1998.
And what education do you have to be licensed as a physician in Tennessee?
I went to medical school at Tulane University in New Orleans, and after that trained in internal medicine at Wake Forest University in North Carolina, and then did a pulmonary medicine fellowship and then a critical care medicine fellowship. And then I trained in lung transplantation at Barnes-Jewish. The fellowships were also in North Carolina. And then after training in lung transplantation, I became the medical director of lung transplant at Vanderbilt University, and then continued on in intensive care for the past 25 years there at Vanderbilt University.
And I'm sorry, sir, did you indicate when you received your licensure as a physician?
Yes, I became board certified in internal medicine in 1993 or 4, and then in pulmonary and critical care medicine in 1996 and 97. And I've kept my, I'm continue to be board certified in critical care medicine. After doing transplant for many years, I just decided I wanted to stay in critical care, so I only maintained the critical care certification at this point. So all I do is ICU medicine, so I just maintained the board certification in critical care, and I'm current in that at this time.
And that licensure and certification has remained consistent since you obtained them?
That's right.
Now, you indicated you're a teacher. Do you specialize in any areas as far as teaching at Vanderbilt University Medical Center?
I mainly teach about how you take care of the most vulnerable people in medicine, the world's sickest patients, those people who are on life support, on mechanical ventilation, on dialysis, people who have a low likelihood of surviving without critical care. And the specific areas that I research the most and care for the most are people who have, well, for example, now in COVID, I'm in the COVID ICU, been in there for a couple of years now, day in and day out with the COVID survivor, COVID patients on life support, but also people with severe sepsis, forms of malignancy, all forms of intracerebral bleeding, all kinds of large vessel bleeding, heart attacks, strokes. And I'm considered, I guess my area, I was trained by one of the fathers of geriatrics. So he always taught me, Wes, how do we take care of the people who are the most vulnerable, that is the elderly, and help them have a dignified dying process. So I really, in the past 15 years, have realized that my job in the ICU is not just providing procedures to help people live, but a third of my patients die by the time they leave the hospital. So I really focus on a good quality dying process, something that allows them to be shown dignity and love during their dying process, and allows them to make as much of a connection with the people that are most important in their life as possible. So, for example, during the COVID pandemic, I was one of the main people who argued with the hospital to reopen the hospital for visitation. And my patients were the first ones that got their family back to the bedside.
Now, you indicated that's been a large focus of your research over the last 15 years, is dying with dignity and helping them. Have you published papers regarding that issue?
Yes, and I never intended to make this an area of my field. I was really just kind of interested in how do we get people off of life support faster to help them survive. But what I realized was that I was carrying around a lot of shame because I wasn't focusing enough on
I believe it's non-responsive. The question was, have you ever published any article?
Yes, and I'm going to tell you how I got to that publication.
Okay, hold on. I get to make the call.
Sorry, you're right.
Okay? I'll give him a little leeway, overruled.
Okay. So you indicated yes. What got you to that point, Dr. Bealey?
So I decided I needed to start publishing papers on what is the appropriate way within the bounds of our legal system to provide good end-of-life care so that people could die with dignity. And what that led me to were papers on the discrepancy between euthanasia and a good, comfortable dying process. And specifically with regard to the doctrine of double effect, for example, and publishing pro-con debates on what is allowable in medicine at the time of death versus not. And so those publications have been a big part of my career over the past few years, as the culture and society has tried to argue one way or the other for legalizing euthanasia.
Now, have some of those research and writing included evidence-based practices that are recommended throughout the nation?
Yes. In 2013, there had not been a redo of the clinical practice guidelines for the safe use of sedation and analgesia pain medications in 10 years. So I was one of the main authors on the clinical practice guidelines for the Society of Critical Care Medicine, which is to say that the society that determines the appropriate use of drugs like fentanyl and morphine published their guidelines, which were then adopted throughout the world as the authoritative guidelines on the use of these medications. And I was one of the leaders of the committee to generate those guidelines.
Now, as part of the research in regards to those areas, did it also include research and writing regarding the withdrawal of mechanical ventilators or extubation?
Yes, actually, that's how I got my entire academic career started. The idea of how to safely withdraw a mechanical ventilator has been one that's been debated for many years. And in 1996, I published a paper in the New England Journal of Medicine, which helped to outline the modern-day protocols for how to withdraw life support. And so I've been on basically most of the committees, guideline committees, and panels of experts to help teach doctors all over the world how is it that we could most safely remove these machines, both to increase survival and also, if someone isn't going to survive, how do we do it in a way that provides a comfortable dying process?
Now, the end of life, obviously, does it touch upon palliative care and hospice care?
Yes, palliative care is an area of my expertise as well. I'm currently mentoring some palliative care physicians, and we're doing NIH, that's National Institute of Health, funded research in the area of palliative care. We are determining the appropriate ways to increase the use of palliative care. I think it's an incredibly important area in medicine that we provide good, safe, and appropriate palliative care to all of our patients who are dying. And this is an area that I'm actively researching, teaching, and publishing in.
In addition to, I think I counted over 300 articles and letters, chapters and books that you've done, including chapters and textbooks, have you taught nationally and worldwide?
Yeah, actually, I have over 500 peer-reviewed publications, and I teach internationally on all continents and travel extensively throughout Asia, Africa, Latin America, the North American region. I'll be going to Brussels in a couple of weeks, and I'm on these. I do that. I don't like being away from family, but I do that because it's important for us to communicate medical advances, and there's really no way to do that without going to the places that are doing the work on the ground and helping one another learn how to do better for other people.
Now, among the topics that you teach on when you travel, does that include the best practices in ventilation withdrawal extubation?
Yes, I'm usually asked to teach on mechanical ventilation itself, withdrawal of mechanical ventilation, palliative use of drugs to keep people comfortable during that process, and to help establish the protocols by which people can approach this safely for people while staying within the bounds of law, but also using science to generate the best foot forward. We can't just wing this. We have to use the evidence. And so I always take an evidence-based approach when I'm asked to give these lectures internationally.
Now, Dr. Ely, in addition to teaching, you indicated you are actually a practicing ICU physician?
Yes, I'm very busy in the ICU. Next week, I'll be back in the ICU at the bedside with my patients, kneeling down, holding their hands, and taking care of them.
Tell us a little bit about your practice in the ICU at Vanderbilt.
Vanderbilt's a very busy intensive care unit. During the COVID pandemic, there were months where it was all COVID patients, but now we've mixed it up. And so next week when I'm in there, I will have probably 20, 25 patients at a time. I'll have medical students, residents, and interns with me, pharmacists, social workers. I make a point to make sure we have the hospital chaplains with us. And so it's a team usually of around 15 people that are going around from bed to bed. And we go in with each patient and their family and round with them for a better part of half a day, and then spend the rest of that day going back to see them again, having family conferences, being with them, and doing procedures. But really, it's more about communication and talking than it is procedures for me these days, because I just find that is the most critical part that's missed at the bedside. So many people get a bad example of communication, and then we start missing one another. So that's what happens. It's kind of a very busy 1 to 2 week block, depending on if I'm on 1 week or 2 weeks at a time.
Now, when in the ICU, are there certain tools that are used to determine the pain a ventilated patient might be suffering?
Yes, generally, and those guidelines I was talking about earlier are called the PAD guidelines, which stands for pain, analgesia, and pain anxiety, and delirium. And we have tools that are validated for use for pain monitoring, and also for anxiety monitoring, and also for delirium monitoring. And that's been a big part of my career, is developing and validating the tools. When I started this in 1998, we didn't have the tools, but now for example, the main tool used all around the world for delirium to see if somebody's awake and alert is one that I developed called the CAM-ICU, C-A-M-ICU, and it stands for Confusion Assessment Method for the intensive care unit. And that's a tool, all these tools that I'd helped develop are translated into over 40 languages and used on all continents to care for patients around the world to keep them safe.
And Dr. Ely, are you also familiar with the Glasgow Coma Score?
Yes.
What is that exactly? I'm sorry, coma.
The Glasgow Coma Score, or the GCS, is a tool that was developed for people with brain injury, like a stroke or a bleed in their head or head trauma. It's not a good tool to be used outside of those areas. So, for example, in a COVID patient, we wouldn't even check the Glasgow Coma Scale. We would check instead the tools that I helped to validate, one of which is called the RASS, Richmond Agitation Sedation Scale, RASS. The RASS and the CAM, which I mentioned a moment ago, are the sister instruments by which we measure if somebody is awake, alert, and thoughtful, and uncomfortable. So what we do in the ICU is we couple a pain tool with an anxiety and a delirium tool, and that is our language. When we try to describe to one another how somebody is doing and if they are suffering, we can use these valid tools to try and help understand if they indeed are suffering or if they are not suffering.
Now, you indicated you helped develop the RAS. Can you tell us a little bit about that?
Yeah, I was, at the time in 1998, everybody was using the GCS. And it didn't make any sense to me because the GCS has never been validated outside of a neuro ICU. And the majority of ICU patients aren't neuro ICU. They're pneumonia patients or heart attack patients. So a friend of mine named Kurt Sessler in Richmond had developed this tool, and I called him, and we developed it and published it in the Journal of the American Medical Association, or JAMA. JAMA is one of the top 3-tier journals in the world. Those top 3-tier journals are JAMA, Lancet, and New England Journal. And when we published this RAS tool in JAMA, it quickly became the #1 way to tell if somebody is comfortable and or sedated enough all over the world. And so the basic schema is this.
But Your Honor, I think at this point we're unresponsive to the question, and I have to object.
Well, I disagree. I'll overrule.
Okay,
But
continue.
I'll keep it short. This is relevant, in my opinion, because what we want to do is ask ourselves, is somebody suffering, and do I need to give more medication to cover their suffering? This is the way I practice medicine every day. And the RAS helps you understand that with the CAM and the pain tool, because otherwise I'm guessing. If the person can't communicate to me, I have to have some objective way to measure whether or not I need to give more medication. And the RAS and the CAM allow me to do that along with the pain tool.
All right.
Bottom line, I can work with my nurse.
Okay, hold on.
Okay.
That's a, bottom line is what, Dr. Ely?
Bottom line.
You ask a new question.
Okay. How is it that you and your ICU utilize that tool?
Yes. Bottom line is that I and the nurse at the bedside assess the patient objectively to see if they are still suffering. You might use my arm as an example. My wrist here is untreated suffering. And I use this example a lot with medical students. If I can see my wrist, then there is still a need for more medication. Okay? If I was able to cover my whole wrist, now, and I'm assessing with the RAS and the CAM, these tools, oh, the tool tells me I'm good. This person is now comfortable. They do not need more medication because more would pose a risk for damage to them. It would make them stop breathing. It might make them die. So if I'm untreated suffering, I'm going to increase my morphine or my fentanyl to try and cover their suffering. But if the suffering is all taken care of, sorry for my weird way of showing you, but if the suffering is covered and we judge by these tools, by the RAS, the CAM, and the pain tool, that this patient is not currently suffering, then there is absolutely no reason to give them a higher dose of a medicine and then only cause harm. Because I want to uphold my duty of first do no harm.
Diane, it's okay if I publish first and just put it on the show. Okay. Your Honor, if I may publish for the
Trying to
jury?
get it up.
All right.
It's showing on the screen here, but it's not going to the big screen. There we
There we go.
go.
All right, Dr. Ely, I'm showing you what's been marked for identification first as State's Exhibit 21. And then I'll move it down so you can actually see what it is. Can you identify this for us?
Yeah, that's the GCS.
And explain how this works based upon what we have here.
So the GCS looks at whether or not somebody's eyes are able to open when I tell them to open them, whether or not they have a verbal response if I say something to them without touching them, and if they have a motor response. And again, this tool for you, if I was to measure your GCS right now, if I don't talk too much and put you to sleep, it would you'd have a 15. So the highest is a 15. The lowest is a 3. The lowest you can get is 1 for each. But that tool was not validated for use in patients outside the neuro-ICU.
Okay. And then I'm going to go to page 3 of that document, Diane. Can you tell us what this is again, States Exhibit 21. Can you tell us what this is?
Yeah, this is important because this is what the world uses now. The world uses the RAS. And if you look at the positive numbers on the top, this is the tool that I validated and published in the Journal of the American Medical Association. So basically, we look at somebody and we say, are they restless or more combative? Which, if somebody was really uncomfortable and in need of more pain medicine or anxiety medicine, they would have positive numbers there. You see them combative, agitated, restless. You right now are a RAS 0. You're awake and alert, and you're calm. That's a RAS 0. And then we have 5 negatives, negative 1 through 5. Now look on the far right where it says verbal stimulation and physical stimulation. This is really, I hope will be intuitive to you, but if I talk to you and ask you to look at me, I'm not touching you, I'm only giving you a verbal stimulus, and I can tell that you do look at me and make eye contact, then I can rate you as either -1, 2, or 3. If when I ask you to look at me and respond, you do not respond at all, then I know that you're at least -4 or -5 at the very bottom there. Physical stimulation required, and you're either deeply sedated or unarousable. Okay? Now, if you are deeply sedated or unarousable, then there's very little likelihood that you need more medicine because you're already deeply sedated and unarousable. You're not responding to verbal stimulation. You can't look at me when I ask. And if I even give you a sternal rub or grab your fingernail and punch down as hard as I can, which is very painful, and you have no response, then that's how deep you are in your sedation, illness, whatever. You're basically, we call that a coma. So -4 or -5 is essentially coma. And then -1, 2, 3 is various stages of deep sedation. It would be really rare, almost unheard of for me, to give higher doses of medications when somebody is already in a coma.
All right, Dr. Ely, what type of medications are you talking about there?
Generally, I'm talking about drugs like narcotics or sedatives like benzodiazepines, Valium, midazolam, lorazepam. These are benzos, or you might know them as sleeping drugs, like Valium, like an anxiety drug. But there are other types of benzos that are more strong than that we use through a vein, and one of them is called midazolam. But the narcotics we generally give in the ICU are either morphine or fentanyl. And we would give morphine or fentanyl through the vein if their RASs were in the positive range, or if they were 0 or -1 or something. We would not want to increase the dose of those drugs if somebody was -4 or -5, because A, their pain is already covered. They don't have untreated pain and suffering. And we don't want to get the negative, the bad effect of the drug, of those drugs, fentanyl and morphine, which is to stop you from breathing.
Dr. Ely, there's another document we've heard reference to called the CPOT. Are you familiar with that?
Yes. Remember I was saying earlier that the guidelines were called the PAD guidelines, which stands for pain, anxiety, and delirium. So I've covered for you the anxiety and the delirium portion with the RAS and the CAM. We didn't cover the CAM yet, but that's a way to tell if your thinking is clear or not. But the P part, I haven't covered that yet. So the P part is, are you in pain? Now, the RAS kind of does get at it a little bit, because if you're in pain, you're probably going to be up there in the pluses. But it's possible to experience pain and not be in the pluses. So therefore, we have a CPOT, which stands for Clinical Pain Observation Tool.
And how is that used, sir?
The CPOT is a 0 to 8 tool, and when people have CPOTs in the 4, 5, 6, 7, 8 range, we judge that they are in pain. And so if somebody had a CPOT in those high ranges, we would want to give more pain meds. But if they were down in the 0, 1, 2, or 3 range, we would judge that they didn't need more pain medication. So for example, if a nurse told me Mrs. Smith's CPOT is 3 and her RAS is -1, I would think she's not in pain and she's lightly sedated, a little drowsy. So she says those numbers, I can hear it as, how is my patient doing?
All right, I want to direct your attention up here. This is the back part of State's Exhibit 21. Can you identify this for us?
Yes, these are the ways that we measure the CPOT. So what we're doing is we're looking at the human being, because the whole idea is I'm there to serve them. So I want to know, am I serving you well enough? Are you tense? Are you grimacing? Are you protecting yourself? Are you restless and agitated? And if you're on a ventilator, one big sign of pain and discomfort on a ventilator is when you're, what it says at the bottom down there, where is it? Yeah, ventilator tolerance. Are you coughing? Are you fighting the ventilator? And we can tell if somebody's fighting a ventilator, because if I give you 10 breaths and you just take the breath, inhale, exhale, inhale, exhale, inhale, exhale. If you flow along with the ventilator the way that I told the machine to breathe for you, then you're not fighting the ventilator. But if every time I tell the ventilator to give you the breath, you exhale and fight and jump around, then I can tell, well, something's not right with Miss Smith. She's very uncomfortable. Maybe she's in pain. And that's part of the CPOT.
And this goes up to a score of 8, you indicate.
That's right.
And it's structured according to how this is laid out?
Exactly. And what we do on rounds is that, are they in pain? Are they anxious? Where are their levels of sedation? And are they delirious? And with that, I can get a clinical picture of what's the degree of suffering that this person's enduring right now. And then we as a team will change our medication plan to try and meet their needs.
Now, just something that you just said, are these tools used alone, or are they used in cohesion with each other?
They have to be used together. They're siblings. I'm not going to take care of your pain and not pay attention to your anxiety or delirium. I'm not going to take care of your delirium and ignore the pain. So I'm trying to get a whole picture of, is my patient suffering? And if they are, I'm going to increase this medicine, because I first and foremost want to make sure somebody's not suffering. And if they aren't suffering by these valid tools, which we've studied in thousands of patients, then I'm going to make sure that we maintain that and reassess them every 4 hours. And time is on our side, because I can always go back and reassess them again and get more information from the nurses.
And Dr. Ely, these 3 tools that I showed you, the Glasgow Coma Score, the RAS, and the CPOT, those are commonly used tools within your business.
Yes.
And what I just showed you are true and accurate copies of those tools?
Yes, they are.
Dr. Ely, you mentioned that typical drugs that you would use in the course of the ICU are morphine and fentanyl. Tell me a little bit about that use.
Yeah, these are really, thank goodness we have these drugs, because they allow us to alleviate the pain that somebody's having, and they allow us to do it safely if we use the right amount. The important thing about that is that each individual person has to be cared for under their own circumstances. And the downside of the medicines is such that I want to make sure that I do good and not harm. The downsides would be, minor things like constipation, but major things like stopping you from breathing and causing you to go into shock and stopping your heart. And we know that narcotics, when given in too high doses, can cause cardiovascular collapse or a drop in your blood pressure and shock, but and very, very predictably can stop you from breathing. So if somebody's not on a ventilator, for example, I need to make sure that I start low and then work my way up.
Why is that important, sir?
Well, it's important because my oath is first do no harm. And if I want to do good for somebody, but I know that a medicine can also do bad, then I'm going to err on the good side and then work my way up so that I'm going good, good, good. If bad's up here, I don't want to start up here with bad, because my goal is to help somebody and never to hurt them. And so I can start low and go high. And what we do in the ICU is I'm up there all day. So we give a medicine at 9 o'clock, a little bit. And we come back at 10 o'clock and give some more. So we commonly give them medicines each hour.
There's no objection.
10 thing is to responsiveness. The question some time ago was explain how morphine and fentanyl use.
Let me take a spin here. Doctor, I know you've got a lot to tell us, but we do it by question and answer.
Okay.
Like your procedures in the hospital, these are ours. So let's let her ask you some questions and we'll work it that way. Fair enough?
Thank you, Judge.
And you just said something about that. Now, we've heard on fentanyl several times, there's no maximum dose medically. What are your opinion on that?
There is a maximum dose of fentanyl.
Your Honor, I would just, sorry to interrupt, but I'm not sure the expert has ever been officially tendered.
Okay, well, you better go sidebar before you go there. Ladies and gentlemen, let's make yourselves busy for a second. We'll be right back with you.
Not great. Well, they're saying it's not great.
There are new CDC guidelines.
Yeah, they just came out. That you can have later for, you know, a later snack.
Exactly. It's that, as I think
Oh, yeah. Oh, they must get really dirty.
I'll take care of things.
you guys doing okay?
We're waiting on her, guys. We'll wait. Okay. It's okay. No pressure, Sam. You're fantastic. You're wonderful. And you're bound up there.
Make sure I write that part down.
No. Unless you want to, I don't care. You ready?
Yes.
Do you want to give the
Repeat the
question again?
Certainly, Your Honor. Dr. Lee, we've heard from other individuals that there is no maximum dose of fentanyl. Can you give us your opinion on that?
Yes, the maximum dose of fentanyl, or the maximum dose of fentanyl, is when the harm outweighs the good. And that gets back to the notion that there is a way that I can hurt you with any medication. And since I don't know your individual maximum, and because the maximum is so dangerous, i.e. that it would stop you from breathing, I have to stay way away from that ceiling, which is why we start lower and work our way up, rather than risking hitting or exceeding that ceiling. That's how we do the maximum dose.
Now, you indicated that the ceiling could cause you to stop breathing. Are there common side effects that could be suffered from a larger dose of fentanyl?
Yes, the common side effects would be a drop in your respiratory rate or the size of your breathing, or completely stopping breathing at all, meaning no matter what, your brain is going to not tell your body to breathe. Because the medication impairs the respiratory center in your brain, the most basic part of the brain which tells you to breathe. So if that medicine hits that respiratory center and tells you to stop breathing, then the way that it will stop you from experiencing pain is through dying and no breathing. And that is the circumstance where we say that the bad outweighed the good.
Do you have an opinion as to whether or not fentanyl used with elderly patients is good or bad?
Fentanyl can be safely used with elderly patients, and I do it. I do it making sure that I stay way away from that ceiling. Usually, for example, I would give doses of 12.5 micrograms, 25 micrograms, maybe 50 micrograms of fentanyl in a single dose, and then repeat that dose if the tools that I have tell me that there's still ongoing pain and suffering. So I would go 50, maybe if I was at 50, then maybe an hour later give another 50. And over a period of a day, I might give 24 doses, all one at a time, making sure that I stay down here in the area of good and never cross that bright line of I'm causing harm now. And that way I can give the medicine safely, keep the person comfortable, cover their pain, and make sure that I never cross over the line of causing them to stop breathing and endanger the natural life that they have been given.
All right, so you just said you might in a 24-hour time period give up to 1,200 micrograms of fentanyl. Would you ever give that all at once?
I would never give that all at once.
Why not?
Well, it's a breach of standard of care, for one thing. The medical literature is very clear on the types of doses that we give for patients who are underneath the care of palliative care. I am, by the way, a primary palliative care doctor. I can also get people who are secondary specialists in palliative care, and the literature shows us that the amount of medicines that people at the end of life get is on the order in 24 hours. And these are the types of patients that I treat with severe sepsis, COVID, cancers, whatever, on the order of around 25 milligrams of on the order within 24 hours of 200 milligrams of morphine over a 24-hour period, which would be in the neighborhood of maybe 1,000 to 2,000 micrograms of fentanyl in a 24-hour period. Divide that up by 24, and you're talking 2,000 divided by 24, you're less than 100 micrograms an hour. So that's why I was saying before that we might give 50 to 75 micrograms of fentanyl an hour on average for dying patients. I have given max ever over that 100, 150 micrograms of fentanyl in a single dose. The highest dose of fentanyl I ever gave in a single dose was 200. And it was to a person who had been receiving fentanyl for 10 days hourly. So, and they had evidence of ongoing pain and suffering from cancer in their bones, broken bones. But I would never give over even 300 micrograms in a single dose for fear of killing them.
All right, now you just indicated the largest dose you gave was because that patient had been on fentanyl for several times. Is that what we call opiate tolerance?
Yes, when someone is given opiates over a period of days, their body builds up a tolerance to the medication, which then allows them to receive a higher dose without stopping breathing. And that does not accrue, that tolerance does not accrue in hours, it accrues in days. So I don't escalate the dose largely in a matter of hours. I always go very slowly increasing. For example, I might go 2 milligrams of morphine, 4 milligrams of morphine, 6 milligrams of morphine, but I'd always give 2, 2, 2, 4, 4, 4, 6, 6, 6, and spread this out over a period of days before I would ever get up to 20 milligrams of morphine. And the way that morphine and fentanyl are converted is by a factor of 10. So 10 of morphine is 100 micrograms of fentanyl. It's different units. 10 milligrams of morphine is 100 micrograms of fentanyl.
And so I'm going to direct your attention to the screen, and I'm showing what's been marked for identification as State's Exhibit 19. Is that essentially what you just said?
Yes, look at the second row, which says fentanyl 10 micrograms is 0.1 of morphine. I think it's easier just to think of it as 110.
Okay.
Okay, hold on, can you guys see that?
Conversion
Or
factor.
you want to
A little bit,
Enlarge
zoom in.
X and 1.
zoom it in?
I'm working on it. How's that?
That actually, is that morphine equivalence? Let me see.
Hold on, can you guys see that better, or do you need it bigger?
So State's Exhibit 19, this would be a conversion chart, and is that to a reasonable degree of your medical certainty?
I'm looking for the morphine.
I believe it's under hydromorphone is what they're talking about, and then...
Oh, equivalence of morphine. I see. Yeah. Oh, I see. Okay, yeah. That's right. Yeah, so that factors what I just said. Yeah, 10 and 100. Yeah,
Okay. And that's to a reasonable degree of medical certainty?
it is.
When we're talking about opioid tolerance, how does a drug addiction, street drug addiction, factor into that in your practice?
Well, if somebody was a chronic, if somebody suffered from addiction, then they would accrue tolerance over time. Unfortunately, I don't know if I'm allowed to keep going with that, but street drug people who are suffering from addiction still die readily when they overdose on a given medication. And right now in our country, fentanyl is the main thing causing most of the deaths that I care for in the ICU. When patients come in overdosed and have had a stroke or brain dead, it's usually now because of fentanyl.
So how would that affect the ability to administer medical fentanyl to a drug overdose who overdosed from fentanyl?
Would you mind rewording that?
Sure. How would that affect your practice if they're on a ventilator, they're in your ICU, you know that they've overdosed on fentanyl? How would that affect what you give them as far as medication while they're on the ventilator?
Well, I wouldn't, if they had overdosed on fentanyl, I wouldn't give them more fentanyl right then, obviously. I would try and achieve the covering of their suffering by some other medicine, because I don't want to continue to pile on to the problem they already have. Is that an adequate answer for you?
Sure. What if they've overdosed on other drugs, like cocaine?
Yeah,
How would that
anytime
affect?
somebody has overdosed on a drug, I try and avoid that same class of drugs as I'm caring for them until I know that that drug is cleared out of their body.
And how would it get cleared out of their body, sir?
The kidneys and the liver generally clear the drugs. Fentanyl has a half-life of a couple of hours, so when I give it, it's going to last not for days, but it's going to last for a couple of hours, and that's why we dose it hourly or every 2 hourly.
All right, now you just indicated it is assimilated through the kidney and the liver. What if there's damage to those organs?
If there's damage to the organs, depending on the drug, because some drugs are more kidney cleared and some drugs are more liver cleared, but we try and pay attention to whether or not somebody has those organs damaged, and we would have to use much lower doses. If they had like kidney damage, we'd have to use much lower doses.
Why is that, sir?
Because the drug will build up much faster and the toxic effect of the medication would be more profound if we don't factor that in, because they have no way of clearing the drug.
Now, Dr. Ely, we've also heard the term chest rigidity used with fentanyl. Are you familiar with that?
Yes, if we give a high dose of fentanyl, think 500 micrograms or more, then the person can get chest rigidity, meaning that they can't breathe. So now you have a second cause of suffocation, is that one is the brain is not telling them to breathe, but the other one is that physically there is this extreme chest rigidity, and so that's another reason why I don't want to get anywhere near those sorts of doses.
What about the use of fentanyl in the extubation, palliative extubation? Have you ever done that?
Yes, I have. When I am extubating patients and have made an agreement with the families on the patient's behalf to keep them comfortable, I want to make sure that I give them drugs that will make sure they're not short of breath. So narcotics have a beauty about them in that they relieve us from feeling short of breath if used in low doses. And when somebody is taken off of a ventilator, I will commonly give them a narcotic so that they don't experience suffocation as they're dying. And the doses that I would give that in would be something like 50 micrograms of fentanyl, maybe 100 micrograms of fentanyl. And that way I'm only treating the suffering of the suffocation, but not crossing over into the badness of stopping them from breathing. So it's that tightrope, that delicate balance that I want to walk with them to do them good and never to harm them.
Now, doctor, obviously you've done palliative withdrawals, extubations in your practice,
Thousands of times.
and you've actually developed evidence-based protocols for such.
Yes, we have a very standard way of withdrawing the life support. We never say withdraw care, because we're never going to stop caring for this loved one, but we do withdraw support. And we withdraw support by pulling the tube out and providing them, assessing them objectively with the RAS and the CPOT and the CAM if they're suffering or not. And as we're pulling the tube out and we watch them carefully, we see, are they suffering? And usually over the ensuing 12, 24 hours, we will give them multiple doses of medications if we see any suffering. If we don't see suffering, then we don't give them those medications, because if there's no suffering, the medicine can only harm them. Another way of saying that is, if the medicine can't help them, it's only going to hurt them.
So can you give us an example of how you would do a palliative extubation, as far as what medication you would use, how you would approach it, that type of information?
Sure. I would work with the nurse and the team, these many people I've got, and we would address a human being as mind, body, and spirit. So we would address their cognitive issues and suffering, their body and their spirit. So we would make sure that the body and mind were addressed with morphine and fentanyl, morphine and maybe a small dose of a benzodiazepine. And so I would say to the nurse, let's give them 2 milligrams of morphine and 25 or 50, and maybe 2 milligrams of a benzodiazepine, Valium or midazolam. If they were on fentanyl, I might say, let's give them a dose of 50 micrograms of fentanyl and 2 milligrams of a benzodiazepine. And we can repeat that dose every hour as you're watching them very carefully, depending on if they are exhibiting a rise in their CPOT. Their CPOT goes from 2 to 7. Oh my goodness, no, they're in pain. Let's increase that fentanyl. Let's go to 100 now. At 9 o'clock, we gave them 50. The CPOT now has gone up to 7. We need to go up to 100 of fentanyl now. So let's double that dose. And it's all through the medical literature shown that the way that we do that commonly in the last 24 hours is we will often double and sometimes even triple the dose. So I might go from 50 of fentanyl to 150 of fentanyl. And that's well established as the right way to do palliative care.
Does it make a difference if that patient is conscious or not as you withdraw them from the vent?
Either way, I would take the same approach, but usually it's just that the conscious person will be more likely to be able to express to me or show to me that they were suffering. The unconscious person, since they can't, that's why we want to use the tools. So when the unconscious person, super important then to use the CPOT and the RAS, because they can't tell me, but I can watch their respiratory rate, I can see if they respond to verbal or if they're grimacing and such.
Do you give pain medication in anticipation of pain that's going to occur with extubation?
Well, we do try and stay ahead of this. So we don't wait until they show pain, but we don't try and jump too far ahead either. So there's this balance. You know, it's all about judicious use of the medicines. And what we talk about, what I teach the medical students is, don't let someone develop a huge amount of suffering, but the easiest way is to give little bits to stay ahead. If this is suffering and this is the medicine and their suffering is increasing, I'm going to stay just slightly ahead, but I'm not going to do this. Here's suffering, here's the medicine. I'm going to stay right ahead of it. And I can do that. We do that every day by just watching the person very carefully.
Why don't you jump ahead to the high dose?
Because I'm trying to do them good. So here's their suffering, and here's the medicine coverage of the suffering. If I stay like this and dose them every hour, then I never jump up here, which causes them to stop breathing and ends their life. It's the difference between, what I'm trying to do is allow the person to die of their natural disease process. Because I am never there to deliberately shorten their life. I don't want to make a somebody into a nobody, okay? I want to allow their natural disease process to take its natural course, and that is like a candle burning out, okay? I'm not trying to blow the candle out. And if I jump up ahead with the medicines, now I'm blowing the candle out, and that's not my right, and it's illegal.
In your opinion, is a palliative care extubation ever an emergency?
It's never an emergency because what we're trying to do is get all of an assessment of what this human being wants, what matters to that person. So we have to be cautious and careful and talk. And they're already on life support right now. We've already got them covered with some form of medication, and we're already watching their suffering. All we're trying to do, so everything is stable, all we're trying to do is say, when is this life support now not meeting the requirements of this person's preferences? And if we think that the person would no longer want that life support, then we, in respect of their wishes, will remove that life support, but it's not an emergency. We have to make sure we get it right. And so we take our time. And we almost never do that in the middle of the night.
Why not?
Because in the middle of the night, families are suffering. The family is suffering. You know, the family is hurting, they're scared, they are in physical and existential pain. So we want that family to be at home, resting if possible, or asleep in the bed next to their loved one. And I don't know what sort of conversation or things that family needs to say to their loved one to help them heal. So I don't want to rush that, and I don't want to do it under the cloak of darkness. I want to allow people to get their sleep. I want to allow them to have the sun up and to be present with their loved one as the dying process goes. And that if we do it at night, it makes it seem like there's some sort of urgency. And then what happens is the family doesn't feel comfortable communicating that love. I've seen relationships rebuild and reconcile even when it's only a one-way conversation. I want to allow that to take its natural course.
What if the family comes to you and say, I want to do it now, doctor, now?
If the family wants to do it right then I try and respect them, but I find out, is this in keeping with your loved one's preferences? and what changed that makes you feel like this is urgent. And so I still try and instill back into the conversation some degree of a pace.
And that's something that comes up. What is your obligation as the physician to the family when you're in the middle of a palliative extubation?
I am there to serve the patient, and in so doing, I must serve the family. So I'm of service to the family.
And when you say you're going to service the family, if it comes down to something that's best for the patients versus best for the family, what's the overriding factor that you have to look at?
What's the best interest of the patient?
And why is that, sir?
Because I am that patient's physician, and it is my duty as a healer to be present with that person to serve their needs, whether it be a comfortable dying process or a curative medication or procedure. They're my primary obligation. The reason I said earlier that I'm there to serve the family is that the patient is oftentimes not able to communicate to me, so the family is my conduit to understand how to serve the patient.
Now, the drugs you administer, what is the purpose of those in palliative extubation?
The purpose of those medications is to try and mitigate or reduce suffering, reduce human suffering.
And we've had some testimony about the synergistic effect of opiates and benzodiazepines. Can you explain that to us, please, sir?
Yes, all that means is that if I give you fentanyl, there is some degree of suppression of your brain telling you to breathe. But if I give you fentanyl and a benzo, or for example, midazolam, it's not just additive, it's exponential. The brain is now getting pummeled in two different directions by two different chemical compounds, telling the center in the midbrain to say, don't breathe anymore. Don't stop, don't send any signal to breathe. And so it's very dangerous to give both medications if we don't monitor the person carefully. Now I do it, but I do it, as I said earlier, very low doses, and I grow it over time, but I would never start high because I would think that I'm going to achieve that ceiling and cause some harm, like death.
Now, there's been also some discussion in the courtroom about opiates hastening the death of the patient in a palliative extubation. Can you talk about that?
Yeah, generally, we do not think that opiates hasten death when they are used in the right doses. If you read any article about palliative care and opiates, most of the articles are actually geared towards making me comfortable to give the opiates. And this is something very important. In the 1990s and early 2000s, there was a general fear of doctors giving opiates, and people died suffering. And that was wrong. And so lots of articles, including investigator friends of mine and ourselves, wrote papers to say, don't be afraid to give these drugs in doses of 2 milligrams, 10 milligrams of morphine, 50 milligrams of fentanyl, 100 milligrams of fentanyl. These doses help people to die comfortably. So the literature's filled with directives that say narcotics don't increase the likelihood of dying. But none of those articles are using doses of 500 micrograms of fentanyl, 1,000 micrograms of fentanyl, 1,500 micrograms of fentanyl. Those are never used in clinical practice to mine. I've never done that. In my whole 30 years of practicing medicine, I've never given a dose of this drug like that. And the reason that none of us would do that is that we know that there's no clinical benefit at that circumstance. We can achieve the goodness that we need to achieve at much, much lower doses and keep the person safe.
Now, Dr. Ely, some of the things that have been discussed that could cause pain to a patient for palliative extubation would be a high lactic acid or acidosis. Can you tell us about that?
Yeah, if you exercise and you build up lactic acid in your thighs, your thighs hurt. It's what stops somebody from running faster. The lactic acid builds up. And in the ICU, patients do get lactic acid. That is not, the way we measure if they're in pain from lactic acid is the CPOT and the RAS, you see. So we don't need a real-time lactic acid level to tell us if they're in pain, because we have these valid tools which allow us to do it right then and there. So I would never say to the nurse, what's their lactic acid? I need to know if they're in pain. No, because I would say instead, what's their CPOT? What's their RAS? If that CPOT's rising, we need to give more pain medication.
What about if they've been administered CPR? How would that affect their pain level?
If they've had CPR, then they have what we call a nidus of pain, a source of pain, because they could have had broken ribs or something. But again, we go straight back to where's their CPOT, where's their RAS, because I don't know. So I need this objective information, and that's what we need in times of confusion is how do I get recentered to know what I'm doing? And the RAS and the CPOT are like our compass. If I want to know where I'm going with this person, then I need to have my compass, and these are the clinical bedside evaluations of each patient that I care for.
And the pain medication you're giving, is it there to help treat the respiratory distress when you remove the ventilator?
If the person starts breathing really fast and appears short of breath, then I would assume that they are sensing the suffocation. And then I would respond by asking the nurse to give 50 to 100 mics of fentanyl and maybe 1 or 2 milligrams of a benzodiazepine. And that would keep them calmer and make them not aware of that suffocation. But that's a low dose that takes care of the bad and achieves me some good without causing bad.
Now, another term we have heard is agonal breathing. What is that, sir?
Yeah, agonal breathing is when, if you have a lot of fluid in your lungs or pneumonia in your lungs, and you can't take a nice deep breath, so somebody is strapping you down and you feel like you need more air but you can't, then I put you on a ventilator. On the ventilator, you're cared for, and so you no longer are agonal. But when I take that ventilator away to allow you to die your natural dying process, when I remove that positive ventilator help, you're on your own. And so you will struggle as you breathe to some degree, maybe, and you'll show me that you're having trouble breathing. And so that's why I say to the nurse, let's give them a little morphine and or fentanyl to make sure that they can't sense that. I want to tell their brain to stop being aware of that sensation. And we do that every day. And we do it with, as I said earlier, broken record, 2 milligrams, 4 milligrams morphine. If they've been on those drugs for a week, I might be up to higher doses. It could be that I'm at 15 milligrams of morphine, 20 milligrams even sometimes, but rare. Remember, even if I'm at 20 milligrams of morphine, that's 200 of fentanyl. So you see, I'm still in the 50 to 200 range of fentanyl, even when they have tolerance.
How would you prepare the family for something like agonal breathing?
That's a really important role of mine. I need to tell them, when we remove this tube, we're doing this because you have helped me to understand that your loved one would no longer want this life support. When we remove it, though, they might look uncomfortable, and I want you to be aware that I will protect them from feeling this discomfort. And the way that I'm going to do that, and I say this out loud, the way that I'm going to do that is I'm going to give them a narcotic, which is going to tell their brain not to be aware of this sensation. So they might look like they're short of breath to you, but trust me that we are doing our best to make sure they're not aware of that. So what I want you to do instead is hold their hand, whisper to them, tell them you love them, and tell them anything you need to know. And that way it gives the family the comfort level of talking to them, even though they see something that looks uncomfortable.
Now, one of the medications that we've heard about a lot is vasopressors. What are vasopressors, Dr. Yeh?
Yeah, we call them vasopressors. Vasopressors are medications to lift your blood pressure when you're in shock. So if you're in the parking lot today and somebody gets a car falls on them and you need to lift that car up, you might get a surge of adrenaline and allows you to lift that car. He's, Superman. That's a vasopressor. Your body did it. But when you're sick, your body might not be able to do that. So I could give it to you through the vein, and it just means that you're in shock, and we give these epinephrine or adrenaline drugs to get the blood pressure up.
What happens if you would remove them from the vasopressors?
If we remove them from the vasopressors, then usually, and we do this, it will make the blood pressure then plummet, and they will die of natural causes. They'll die naturally, which often means, by the way, that we don't need much in the way of morphine or fentanyl, because their dying process is going to be rapid anyway. And so I can usually give them very low, very, very low doses if they're already on vasopressors. In other words, I'll say it another way. If you are on vasopressors and I'm removing life support, it means that I very likely need to give you almost nothing in the way of fentanyl, morphine, or benzos, because you're going to die very rapidly anyway, usually. It could still be hours to days, but it might not be that long. But I don't feel the need to keep ramping up these medicines because it's going to happen by nature. So there's no reason to impart a human action to cause that dying process.
All right, and we've heard that there is two ways of dying, by your heart stopping or you stop breathing. Can you comment on that?
Yeah, medically, cardiorespiratory, so heart, lung. So when you die of either of these two organs stopping, they usually kind of occur together. It's very rarely one or the other. Because if you are stopping breathing, it stops oxygen from getting to your heart, so your heart stops too. You see? And if your heart stops, you stop pumping blood, which then makes your lungs fail as well. So these things kind of go in tandem. So I'm never at the bedside thinking that was purely lung or that was purely heart. It's usually kind of all of that happening at once. Is that what you kind of wanted to know?
Thank you. One of the first things you'd mentioned when you took the stand was the doctrine of double effect. We've heard a lot about that. Can you explain it to us so us laymen understand it, sir?
Yes, okay. So the doctrine of double effect means that when I do something to try and help you, it might also harm you. And as long as I am always trying to help you, if the harm occurs, but it wasn't the intent, then it's happening as a double effect of the medication. So the medicine has essentially a capacity to do two things. I'm going to try and say this for you kind of two different ways, okay? The medicine has a capacity to help you, and it has a capacity to hurt you. The doctrine of double effect is said to be in place if I'm intending good and never harm, if the good is not achieved by the harm, and if the good outweighs the harm. I'm going to say these again. And a fourth criteria, that the good couldn't have been achieved any other way. I'll say them again. The good has to be the intent, never the bad. The good cannot be achieved by the bad. The good should outweigh the bad. And there can't be any other way to achieve the good. Now I'm going to give you an example and I'll stop talking.
Okay.
I think it's unresponsive at this point.
I can ask another next question. Can you give us an example, Dr. Ely?
Yes, here's an example. If a person is in pain or is short of breath, and I want to relieve that suffering, okay, I can give a low dose of a narcotic to tell the brain to stop to relieve their awareness of the suffering or relieve the pain, and to try and help them. Okay? If, however, this is how the doctrine of a double effect would not be in play. This is how I would reach the doctrine of double effect. If instead of giving the low dose, I gave something that hit the ceiling, and now the way that I achieved the relief of the pain and the shortness of breath was by stopping their breathing and their dying occurred, because now the death, which is the bad, caused by my drug, has outweighed the good. The good was achieved by the bad. And I could have achieved the good by just giving a low dose. All I had to do was give 100 instead of 1,000 or 500. If I had given 100, I would have done something helpful without causing the stopping of breathing. Their dying process could take its natural course. I wouldn't have created that because of my medication. Is that helpful?
So does the literature support what you just told us about looking at the dose?
The literature supports that it is appropriate to cautiously use these medications. And I told you earlier, an average dose, even in the last moments of death, would be, the high doses would be in the neighborhood of 200 micrograms of fentanyl, would be on the high end. And this is supported by the medical literature. And that is a way to go. There's no literature on using 500 micrograms, 1,000 micrograms, 1,500 micrograms of fentanyl. There's no literature on that at all, because nobody does that. So I couldn't find anything in the literature of routine use of those doses.
So in your opinion, with those type of doses you're talking about, 500, 1,000, 2,000, could be purposeful to cause the death?
Objection, Your Honor.
Let's rephrase.
Okay. Those type of doses, how would you take that as to demonstrate what the intent is of the physician?
The only logical intent that I can come up with for using those doses is to stop somebody from breathing entirely.
And that would lead to death?
It would lead to death, certain death. It would be a lethal dose.
So would you agree with me at most purposeful, at the least reckless?
Objection, Your Honor.
Okay. Format of the question, sustained.
Sure. That type of dosage, would you say that that would be purposeful action?
Objection, Your Honor.
Okay, again, form of the question.
Okay. How would you define that type of dosage as far as the intent?
Objection, Your Honor, as to how does he define intent. Intent is a legal term, and I don't believe he set forth any qualifications with respect to him having a JD.
Again, form of the question.
Medically, those type of doses given to a patient in palliative extubation, what do you believe the intent of that physician would be?
Same objection.
This time overruled.
I believe the intent would be to stop breathing and hasten death, cause death.
That's to a medical standard, correct?
Yes.
Your Honor, I'm next intending to get into the actual victims in this case. I don't know if
Maybe
this
it's
would be a good
time
time
for
to take a
then.
break.
We're going to give you your early 15 minutes. Okay? Remember the admonitions.
All right.
Have a wonderful break, ladies and gentlemen. We let them get out of the way since you guys have to cross each other. When we discussed the construction of these courtrooms, that was one of our complaints, but unfortunately we weren't writing the check, so. We do sanitize that area.
Thank you.
So it was all that was, the whole room was done over the weekend, so. Okay. Doctor, you cannot discuss your testimony on the bench. You can answer factual questions, anybody that propounds upon you, but But how you testify and what you testified to, you are not to discuss. Do you understand that?
Yes.
That if you need to step down, get comfortable, find a restroom.
Thank you.
Ms. Sawyer, anything for the record? Ms. Benassi? Okay, we're on break. Well, I didn't take my meds this morning. My muscle relaxers, which doesn't put you to sleep, and I have a Nedstead that I can take.
No, he's fast. Well, when he gets into it, he's fast. Yeah. Sure. And she's usually right there with the next question before he's finished talking. I'm going to wait until it's back. And it could just be me today. That's the lead.
He's elevated him because I was like, so behind Carlos really good society, making all these guidelines. So how does it affect Scherzinger testify?
I'm going to start the bus today.
But he's not going to like me. So I don't, this is why I don't do it tomorrow. Sorry. People, yeah. Wait, this is amazing. I told Ben to go get something. Because this is, you know what I told him? This is going to fall for
I didn't mean to be that much of a smart aleck when we went back on the record that one time.
Oh, it's okay.
It's your family.
We got to giggle with this. I mean, it's a very respectful proceeding, but we don't fall into the quagmire getting too serious. This isn't my favorite chair, but we We didn't want to take it off the bench. We may have to this afternoon. See, I think they sent one of my chairs away when they moved this over. Because I went and got St. John's chairs, which are like really good chairs, but they had a clearance at one of the local places. So I got them for like 25% of their normal price. We got two of them. Well, for some reason, I don't think they both came over. Or someone else is sitting in one of my comfortable chairs.
Somebody's like, I want a chair of water.
And I didn't want to walk around the courthouse peeking under people's chairs. But see, you know, being in private practice and having my own office with furniture and everything, you know, I was pretty good about getting a deal.
Yeah.
Because office furniture is usually by the pound. You know, you can tell a good desk by the weighing so much. And when I came to the bench, I basically gave it to all the guys in the office. Jurors. I wasn't going to liquidate it. Now I wish I had some of it and had storage for it. I'd love to have. My desk was a Kimball, but it was a good Kimball. That thing probably weighed 300 pounds. And it was big, but it was a great desk.
Say that you're sorry. Is that
Rebuild my relationships.
I'm ready now.
If I ever how I could extubate it, if my mind shows up, we don't want to rebuild a relationship. No. I don't speak to her for a reason.
Oh, just by himself? Did you check in with Rachel about check in, do some resources, or somebody that can get it?
It says he's never given it.
In social services, she's really struggling. I hope so. Some sort of grant or anything, we can like get her in touch. Just my case was an accident murder with her husband. But she had before she had somebody. You're just doing it.
Yeah, the sonic practice tonight, so I might get home by 10:30.
10. This was like an exhibition. I just can't, but that's okay. That's okay.
And it's my favorite night of television, too. NCIS and NCIS Hawaii on tonight. Having a bad hair day.
I think they're fairly well in order, so I'm just going to lift them up one at a time.
Yeah.
Do you want me to come out and do that? Okay, I'm happy to.
Paul's my boyfriend. We started watching 8 Rooms a few weeks ago.
That's a long series.
Yes, we've been binging.
I can be up here very
Well, the
late.
weekends is
This weekend I didn't have time to binge anything. Oh, I got home on Friday, did 3 got 2 suits actually and some shirts.
Yeah.
You know, and get some gas. Huh?
So we kind
Huh? What, you're cross?
Sometimes, like, do you remember back in the day where you just used
One of those, just put your ears back and go. One of those, you put your ears back and go. Because anywhere you can control damage, you try.
I'm trying to set a meeting up.
So, although I didn't sleep last night,
Yeah, so whatever people we can hook her up with. I would really appreciate she's a sweetheart. She just, her husband was awesome. He had just gotten murdered. Just doing his job. So it was like, they did a handyman company, and it was like looking outside our apartments. And, you know, our thoughts were that he
Why don't you go and gather them up?
So it is like one of those victims of victims. And then so I'm just trying to do what I
Because usually I take that muscle relaxer before I leave. I mean, it doesn't make me sleepy or anything.
right.
And the next day,
All right.
Dr. He's in the restroom.
where's the doc?
He's in the restroom, Your Honor. He said he'd be right in.
seated. The doc had to go to a room for a second. Coffee and everything good, guys? Everybody got coffee? I forgot the teapot this morning. That's my fault.
You know what, Judge? I have a traveling teapot. I'll just bring it.
It's up to you.
Yeah, I'll bring it. Thank you.
I do have 3 of them, though.
Me too. I'm the one drinking it.
Well, the one I used for risotto,
Right.
so I don't think chicken broth is a good thing to make your tea out of. Did we lose the doctor?
He's in the restroom, Your Honor. We should have him in a minute.
Okay. That's the longest walk from that door to the stand. Come on down, Doc. Yeah. Doctor, remember, you're still under oath. Go ahead and get yourself comfortable. Ready?
Yes, sir.
Okay, you may continue.
Dr. Ely, were you asked to look at the medical records of the 14 victims in this case?
Yes, I was.
And did you in fact look at those medical records?
Yes, I did.
From there, did you draw up a report, your report regarding this?
Yes, I did.
And Your Honor, if I may approach the witness?
You may.
Dr. Ely, I'm handing you what I marked for identification as State's Exhibit 30. Could you identify that for us? And I believe it's in 2 parts.
Yes, in this binder, the first one says CV, and that's my curriculum vitae.
In the second part?
The second part is my report on the patients, which I believe was redacted from 25 down to the 14 that you're including today.
And is that a true and accurate copy of your report
Yes, it is.
that you prepared in response to this case?
Yes.
So I want to direct your attention to the first victim, Joanne Bellisson. And State's Exhibit 1, which is 2 volumes.
Okay, hold on. When you say CV, what do you mean?
Oh, I'm sorry, my resume. CV is curriculum vitae, which is a resume.
Okay.
Those will be the medical records of Joanne Bellisson that you examined in response to this case? Is that a yes or no, sir?
Yes, it is.
Okay. And I'm going to direct your attention. You can look at your, either the binder or what's on the screen. Can you tell us what this is, sir?
These are some summaries of my thoughts, my observations about her medical records.
All right. And what did you find important in looking at Joanne Bellisson's medical records?
Well, this woman had she had a disease which is dangerous for the body, which is chronic obstructive lung disease and kidney failure. She also had a big problem with blood pressure, and that when the blood pressure goes too high, it can cause your brain to not work well. So her brain wasn't working well from the blood pressure. She had underlying lung disease, and she also had kidney problems. So those were the underlying issues that she suffered from, and she did not have any cancer as diagnosed by looking down at her lungs. And the main thing that occurred was that at the bottom of the screen, it shows that at 23:32 that evening, she was given 1,000 micrograms of fentanyl at the time that she was extubated, and she died 8 minutes later.
All right, and she was admitted first to the hospital on April 22nd of 2015,
Correct.
and her death occurred on May 10th of 2015?
Correct.
Now, why is that amount of fentanyl important to us?
Well, she didn't, it's unclear from looking at these medical records how long she would live. She could live for days, she could live for maybe weeks. We don't know that. And when she was given 1,000 micrograms of fentanyl, she only lived for 8 minutes. And I think it's because her brain was completely shut off from delivering any more breathing by this, what I deem a lethal dose of the medication.
All right, and did you draw conclusions then based upon your review of those medical records?
Yes.
And were those conclusions made to a reasonable degree of medical certainty?
I think they are made to a reasonable degree of medical certainty, and I think it was unethical to give her 1,000 micrograms of fentanyl when we did not know how long her natural life would lead, and I think that we assured that she would not live by giving that dose, which to me is the cause of her death.
All right, and that's essentially, if I'm correct, the first paragraph here that you're talking about?
Correct.
What were your specific findings regarding that dose?
The specific findings are that there was no indication to give that dose. That if a desire for making sure that she wasn't suffering because of her chronic obstructive lung disease was present, she could have received 50 micrograms of fentanyl, 1/5 of the dose. I mean, what would that? 1/10? Yeah, 5% of the dose. She could have been given 5% of that dose, and 2 times 10, 20, or I guess that's right, yeah, and done and achieved a good for her. She could have been safely escorted off of a life support device, and then allow her life to go on, but instead her life was stopped.
Now, I note that you make a specific finding that the procedure of palliative extubation is not painful or uncomfortable. What do you base that on, sir?
We have studied thousands of patients who have undergone extubation and discussed with them if the extubation itself was painful. And patients don't describe that to me, that taking the tube out is causing them pain. What can cause them suffering, of course, is a shortness of breath. But as I said, 1,000 micrograms of fentanyl is not what you use to take care of that problem.
Was there any evidence that you saw of opiate tolerance within Ms. Bellisson?
I do not think she had opiate tolerance. So I think that this medication was given to essentially a person who could not have tolerated it under any circumstances at all. She had received a few doses for breakthrough pain before, but very low doses. And what's interesting is that the cross tolerance from hydromorphone and morphine to fentanyl is not very good. In other words, if I get given morphine and hydromorphone, which is dilaudid, for multiple days in a row, I don't develop as much tolerance for fentanyl. Fentanyl is a unique beast. It doesn't have when you develop tolerance to morphine, you don't automatically have tolerance to fentanyl, which is why we are so cautious about that one specific drug, fentanyl.
What about whether these type of medications, the 1,000 micrograms of fentanyl, how would that affect Ms. Bellisari's body?
Well, she'd be unable to keep living with that drug.
And is that based upon a reasonable degree of medical certainty?
Yes.
What specifically with her and her illnesses would have helped to contribute to that?
She has kidney problems, so she can't metabolize the drug, so it's going to come into her and stay built up. But even if she didn't have the kidney problems, I think that would be a lethal dose. You cannot keep breathing when you're given 1,000 micrograms of fentanyl. All of you would stop breathing.
And I'm going to go to page 2 of your report regarding Ms. Belisari. You indicate here, fentanyl is a high alert medication. What does that mean to us?
What it means to use, anytime a person is given fentanyl, they have to be very carefully monitored for the likelihood that they will stop breathing. And if they are not going to be protected by being put on a ventilator, then we have to make sure that we don't give them a dose that would cause them to stop breathing, or otherwise we're causing the death. We don't ever want to cause the death. We want to reduce suffering, but never cause dying.
And in addition to her kidney failure and organs, her age, did that have an impact on how quickly this affected her?
Anybody of advanced age will be less likely to be able to tolerate this, and don't forget that her lungs were severely damaged. So she is that group of person that I was talking about earlier at the beginning of the day is, how will I care for the most vulnerable members of society? And she falls into that category. So this is, I think, a reckless approach of giving medication to a vulnerable human being.
And what do you base that upon, sir?
30 years of medical experience and the summation of the medical literature and the science.
And that's also to a reasonable degree of medical certainty that at the least it's a reckless approach? In that report, true and accurate copy kept in the normal course of your business?
Yes.
The next patient, sir, would be Ryan Hayes. And did you examine State's Exhibit 2, which is the medical records of Ryan Hayes?
Yes, I did.
Based upon that examination of those medical records, did you author a report regarding the death of Ryan Hayes?
Yes, I did.
And did you make findings based upon the medical records?
Yes.
Those findings to a reasonable degree of medical certainty?
Yes.
What did you find significant regarding Ryan Hayes's medical background on or about April 3rd of 2017?
Sure. This is a person who had polysubstance abuse, so he had an addiction. He had the disease of addiction. And unfortunately, he overdosed as an outpatient and was brought into the emergency department as a result of this overdose. And he was evaluated in the hospital and found to have severe swelling of his brain. So what that means is that when he overdosed at home, he already stopped breathing. And when he stopped breathing, he didn't get enough oxygen to his brain. And so his brain, the neurons in his brain were dying. Millions and millions of those neurons were dying. Now, what the long-term outcome of that is at this point in this man's life, we don't know. We don't know how much recovery he's going to get. He's a 39-year-old man. So he's a very young person, and even though there's that much damage, we have had people come back from that. There are people who live through that, and I don't know, since I'm not God, what his outcome will be. But what happened with him was this. His initial evaluation, he didn't have these baseline reflexes, a gag reflex, his pupils weren't working right, his corneals, etc. So when that's going on and the person's brain is swollen, and they don't have these reflexes, we start wondering, are they all the way dead? And he was evaluated and not found to be all the way dead, meaning his brain wasn't dead. He would still breathe, so he wasn't completely processed to death. And then he was given 1,000 micrograms of fentanyl, and the dose was given at 22:57, and 33 minutes later, he was pronounced dead. So, in summary, we have a 39-year-old man who, unfortunately, because of his disease of addiction, already has been placed at risk for lack of oxygen and with ongoing brain damage. We need to see what's going to happen in the next 24 to 48 hours. That's our standard procedure. What will happen in the next 48 hours to this human being? But instead, that process was short-circuited by giving him 1,000 micrograms of fentanyl, which 33 minutes later resulted in his death.
All right, and so to be clear, to a reasonable degree of medical certainty, Ryan Hayes was not dead at this time before he received that medication.
He had not progressed to the full period of brain death, so correct.
And just, I want to go back to the first paragraph. You indicate, just so we understand, he had polysubstance abuse, and you indicate he was administered Narcan. Can you explain to us what that is?
Yeah, Narcan is a medication to override the effect of the narcotic. And if someone overdoses on a narcotic and we give them Narcan, it can allow them then to continue breathing and live on.
Now, you indicated earlier that he didn't have a cough, he did not have a gag, his pupils were fixed and dilated, no corneal reflexes. What does that mean to us as lay people?
That there very well might be some severe brain damage, but it's early, and we don't know yet what the full outcome can be. These things can recover.
Now, we talked a little bit about Glasgow, CPOT, all of that. Do you remember whether or not he had any ability to feel pain based upon the review of the medical records?
I'd have to be shown the medical record because it's a lot of, I don't remember the details of that.
He was diagnosed with an anoxic brain injury. What does that tell us?
That shows that with anoxic brain injury, it's very unlikely. In other words, what I was saying I remember is I don't remember his actual CPOT scores and that sort of thing, if that's what you're asking me. I would not be worried about this person being in pain. He already is in a deep, deep coma, and it's highly unlikely that he is experiencing or aware of any pain.
All right, then you went on to talk about the fact that at 2257, he received 1,000 micrograms of fentanyl. Did he receive any other medication at that time at 2257?
He also received 10 milligrams of hydromorphone, and 10 milligrams of midazolam. This is an astounding amount of medication. This is so far out of the norm of what we would do for somebody. It would essentially be like, if I was going to transport this human being safely through suffering, I was thinking about this morning. Maybe it would be like, I've never said this out loud to anybody before, but if I'm allowed to offer an example, it would be like if I wanted to get somebody safely through a school zone, to keep a child safe, I might drive 10 miles an hour in the car, go very slowly, and make sure that the people crossing weren't hit. This is like driving 250 miles an hour through a school zone with people walking across the street. It's that kind of out there. To get any one of these medications might not be necessary, but to give all three in that high of a dose, it's mind-boggling to me why anybody would do that.
Well, then, what do you note on April 3rd, 2017 at 2314 and 2317? What is important to note there?
He wasn't breathing at all.
And then what
he had been
happened?
breathing earlier. Earlier, he was put on the ventilator at 4, and he breathed 6 to 8, meaning that his body was saying, keep breathing, keep breathing, keep breathing. And so he was breathing above the breathing machine earlier, which was at 8 o'clock that evening. But at this time, he has no breathing whatsoever after those medications, which is not at all surprising. There's no way the body's going to keep breathing after receiving 1,000 micrograms of fentanyl, 10 milligrams of hydromorphone, and 10 milligrams of midazolam.
What happens at 2316 then?
He received more.
And what specifically did he receive as far as medication at this point?
He received 1,000 micrograms of fentanyl, 10 milligrams of hydromorphone, 10 milligrams of IV midazolam.
Hypothetically, Dr. Ely, if his pain scores is 0 throughout his stay at the hospital, what would be the purpose of administering this type of medication to him?
There's no purpose other than to end his life.
Did you, based upon this information that you found relevant, draw conclusions regarding Ryan Hayes?
I think that these drugs were given to intentionally cause him to die.
And is that to a reasonable degree of medical certainty?
I think yes.
Was there anything that you found in the record to show that he needed this type of medication and level of dosing?
There's no medical indication for these 3 medications in the doses they're given at all. The patient was already in a deep coma. He was not exhibiting any signs of ongoing suffering.
And again, palliative extubation, is it painful based upon your experience?
Not painful, and even if it was, you might give 1 dose of 1 drug of 50 micrograms of fentanyl, which would be fine. 1 dose of 50 milligrams of fentanyl, but to give 2 doses of 1,000 each, and the hydromorphone, and the benzodiazepine, there's just absolutely nobody would do that in medicine.
What about his history of ongoing substance abuse? How would that affect those dosages?
No amount of tolerance to those medications would justify these doses of these medications.
And going to the second page of your report regarding Ryan Hayes, anything else regarding, was there any sign of symptoms of withdrawal that would account for these types of doses?
No, he did not show any signs of withdrawal at all. And so I also saw no support for the medication use with regard to that either.
All right, now you mentioned Narcan here. Why did you mention it at this point?
Well, because you might think, oh, if there's Narcan in the body and I think he's suffering, let me give more of a dose of this drug. But there's no Narcan in his body at this point. It would already have washed out. So that also is just, it's kind of not that big of a point, but it's just, there's no support for these drugs at this point.
And the Narcan, I think you said previously, would also wash out anything else he had taken as far as the illegal substances from his system?
That's the goal.
Okay. You comment at this page about the pain score. And Your Honor, if I may approach, I think I found what he was looking for. I'm handing you what's been marked as Exhibit 2. Hang on just a second. 2D.
2B would be
2D.
2D.
Yeah.
Okay, 2D or 2B?
2D as in dog, Your Honor.
Okay.
And actually, Diane, okay if I just publish this? Sure. Okay. I'm just going to put it up here for you, Doctor.
Okay.
This is regarding, first off, 2D. You see the number at the bottom?
Yes, I do.
All right. And this is regarding what patient, Dr. Ely?
Oh, I'm sorry. This is regarding Mr. Hayes, Ryan Hayes.
All right. And this is what you're referring to pain score. Is that accurate?
Correct.
And what do we have as the history of the pain score at this time?
Yeah, so what you see here is that on April the 2nd, throughout the day, as you're going through the evening, the pain scores are rated 0 all the way down until suddenly somebody puts down 4 10s.
All right, and I want to direct your attention. The first 2 10s are 2257 on April 3rd,
Correct.
and the second 2 10s are at 2316.
Correct.
All right, going back to the first page that you had talked about regarding Mr. Hayes. What time, how do I get rid of this?
You gotta go to the mechanism at the bottom and hit clear.
Look at that. All right, what time was the first dosage of fentanyl, hydromorphone, and midazolam given in paragraph 7 of your report?
2257.
And what about the second dose of those medications?
Was it 2316?
Patient in Mr. Hayes' condition able to feel 10 on pain?
No, and is that a yes, or is that just a single word
Yep.
answer you want?
That is perfectly acceptable, sir. You also note on the second page of your findings an issue with that 10 on pain. What is that, sir?
Yeah, if you remember earlier, I was telling you that the CPOT score goes from 0 to 8, so there's no 10. And what I think happened here,
Objection, Your Honor.
Okay.
As to speculation.
there's no 10.
Okay,
You can't have a 10.
stop,
Okay.
stop, we have an objection.
I can re-ask the question, Your Honor.
Ask the question. that
What
Bev
is wrong with
sustained.
this?
Okay, I'm sorry.
I'm sorry?
Objection sustained. Re-ask the question.
Thank you, Judge.
A new question.
What is wrong with a pain scale of 10 using the CPAP?
It's not an accurate representation of the scale, so somebody wrote that down, made a mistake, or did something out of context from medical practice.
And based upon your review of Mr. Hayes' medical records, based upon that, would he be capable of feeling a pain score of 10?
Ask and answer. Objection.
I will permit it. Go ahead.
You can answer that.
No.
And is that to a reasonable degree of medical certainty?
Yes.
You also indicate in your report that Mr. Hayes had not yet appreciated the full effect of the medication administered to him at 2257. Explain that to us, please, sir.
Yeah, he was given doses just 20 minutes earlier that would take down an elephant, and they had not had the full effect because the drugs are still increasing in their effect on the body at that time. So the amount of impact of stopping breathing is growing inside his body at the time that he's then given a double dose even more. We would have wanted to see that drug go play out for 3-4 hours at high doses before ever touching him with any more medication. But instead, only 20 minutes later, he's given the same amount again, which just completely ensures that he cannot breathe.
And based upon your review of the records, do you have an opinion as to a degree of medical certainty as to what caused Mr. Hayes' death?
Absolutely.
And what is that, sir?
He received lethal doses of fentanyl, hydromorphone, and benzodiazepine.
Did you also review the medical records, State's Exhibit 3 of Beverly Scherzinger?
Yes.
And based upon that review, did you draw a report?
Yes, I did.
And did you reach conclusions based upon that review?
Yes, I did.
All right. And based upon your review, what did you find that was significant from Ms. Scherzinger's medical records?
Well, she developed a blood clot after coughing and came in the emergency department. She was verbally alert and she was oriented. She was determined to have internal bleeding, which was the complication of a procedure that she had. And it caused her, when you have this much bleeding, it can cause you to go into cardiac arrest. That made her then have the need for a ventilator. So she was put on the ventilator to protect her during this time. And she, on the ventilator at 2254, was obtunded, not oriented. So a coma. And at 2320, she was palliatively extubated with PRN sedatives, but the amount of sedative she was given was extremely high, 500 micrograms straight out of the gate, and 4 milligrams of midazolam. And then she was off the ventilator at that point. So she'd already had trouble breathing earlier. She's now taken off the ventilator and then given those medications, and she died 14 minutes later.
And that occurred on October 9th of 2017, her death?
Correct.
And she first came into the hospital on October 2nd, 2017.
That's right.
You used the word on October 9th, 2017 of obtunded. What does that mean to us, sir?
Obtunded means that if I press your chest or if I press your fingernail beds and cause pain, that you don't react. So you're in a coma.
Now, you also comment after her death, did the biopsy come back regarding Ms. Scherzinger's liver biopsy?
She had lung cancer, and it was believed that the amount of lung cancer she had, the severity of it, that she would live for years.
Based upon your review of the medical records, did you draw conclusions to a reasonable degree of medical certainty?
Yes, I did.
And what were those conclusions, sir?
I think that in a patient like this who has a type of lung cancer who can live for years, that the medication that she was given caused her death. She did not die of lung cancer, and she did not die of the complication from the procedure. She died of the medication she was given, which stopped her from breathing.
Was there anything that you saw within the medical records to support this level of dosage of fentanyl and midazolam for her?
No.
What other issues did you see within those medical records?
Well, this is a human being who went to the doctor to try and see what was wrong with her. A cancer was diagnosed, and she was not given the chance to get curative treatments for that lung cancer.
Was there anything regarding prior opiate therapy which would have led to her needing this type of dosage?
No.
Anything within her own body that would cause this type of dosage to be a problem for her?
Well, for one thing, when you're in shock and you're obtunded already, then you're very vulnerable to these medications. You already have ongoing brain that's not working well, and then you add this degree of medication, so you're going to be very unlikely to be able to fend off that degree of medication. That's my answer.
Do you have an opinion as to to a reasonable degree of medical certainty as to what this dosage to her, what it resulted in?
I think it resulted in her stopping breathing and caused her an untimely death.
Sir, I'm next going to direct your attention to Danny Millette. Did you review States Exhibit 4, which are the medical records for Danny Millette from Mount Carmel?
Yes, I did.
From your review of those medical records, did you draw up a report?
Yes, I did.
And did you reach a conclusion to a reasonable degree of medical certainty based upon that report?
Yes.
What information to you was relevant in reviewing Danny Millette's medical records, sir?
This was a sick man. He had a lot of underlying medical problems. He had diabetes, blood pressure problems, lung disease, and he came in with a gangrenous right toe, which meant that his blood vessels in his body were already damaged from the diabetes and hardening of the arteries. So he was a very vulnerable person at the time that he came into the emergency department. He was found unresponsive by his family, by his wife, and he had been living in an extended care facility. So you are already getting the idea this is a frail human being. He's not thriving in life at this time. But people live in frail circumstances with these diseases for many years. We just have to be careful with them.
What about when he finally did come into the hospital, was he ultimately on a ventilator?
Yes, he was a full code. He had advanced life support. He was given vasopressors, as we discussed earlier, and he, though, regained his circulation. He responded to that life support, and he had shock, kidney problems, liver problems. He had anemia, and on the 5th of, sorry, I'll stop.
All right. December 5th, 2017, did you review what his Glasgow scores were at that time?
Yeah, so this sick gentleman had Glasgow scores of 3, which is the lowest you can go on the Glasgow coma scale, meaning that he was in a deep, deep, deep coma.
And on December 5th, 2017, it notes that his code status was changed to DNR-CCA. What does DNR mean to us, Dr. Ely?
It means do not resuscitate. So we're going to allow his life to take its natural course without any more CPR. We're not going to try and increase his death. We're not going to try and cause him to die, but we're not going to shock him or give him chest compressions.
And on December 5th, 2017, what type of medication was given to Mr. Millette in the course of palliative extubation?
Yeah, at the time that he had a GCS of 3, in that deep coma, he was then given 1,000 micrograms of fentanyl through his veins, and that same mysterious pain score of 10 appeared.
Was he given any other medication around that same time period?
He also received the hydromorphone, 2 milligrams, and 4 milligrams of IV midazolam, the benzodiazepine.
Based upon your review of the medical records and your expertise, to a reasonable degree of medical certainty, did you draw any conclusions regarding how those drugs affected Mr. Millett?
I think they stopped him from breathing and caused his death.
What did you find significant regarding his medical records and these doses?
Well, he would not be able to tolerate those doses given that he had underlying liver and kidney disease and heart disease. So those organs were already so tender and frail that if somebody was worried about him suffering, which he was in a deep, deep coma, so it's unlikely that he would exhibit any pain or suffering, you'd have to give extremely small doses, maybe 25 micrograms of fentanyl or 1 milligram or even a half of a milligram of the benzo, and not both.
And you indicate that up until the time of the administration of this medication, his pain scores were also noted as 0?
Yeah, that was what was so odd to me. It's 0, 0 all the way down. There's no evidence of pain, and all of a sudden it jumps to this undocumentable level of pain because 10 isn't even a real thing. So I don't know what actually happened there. I wasn't there. But it's almost as though somebody said, I better justify the amount of medicine I'm giving, so let me make sure that
Objection, Your Honor. He just said he wasn't there, so if anything else is speculation, I move to strike.
Your Honor, he is an expert. He's allowed to at least give his opinion regarding that.
I'll permit it.
You can finish your sentence, Dr. Ely.
patients don't go from 0 to 10. Nobody does that unless you just all of a sudden jab them with a knife or something. Patients go from 0 to 2, and from 2 to 3, and from 3 to 5. But to go from 0 to 10, there's just nothing in his chart that supported that he all of a sudden went off the scale on the pain chart. And I mean off the scale because 8's the highest. So I don't understand. It doesn't make any medical sense.
Now, moving on to the second page of your report regarding Mr. Millett, you talk a little bit about 4 milligrams of midazolam and what that would be appropriate to be used on as far as a patient. Tell us a little bit about that, Dr. Ely.
Well, that's a lot of midazolam. I mean, if I was giving you midazolam, I would give you 1 or 2 milligrams. But your liver works, your kidney works. But if I had already given you 1 or 2 on another occasion, I might give you 4. That'd be fine. But I wouldn't give 4 to somebody who was already in a coma and didn't have a working liver and kidney.
Now, you also talk about the fact that he was given fentanyl and hydromorphone. Why is that significant?
Well, they're both narcotics. There's no reason to give both of those. I've never given those two together, ever. Absolutely no reason. It'd be like, okay, it'd be like giving 2 different types of blood thinners, heparin and Coumadin. And your blood is already thin on one, and I add another one, which can only cause you harm at that time.
And did you draw a conclusion based to a reasonable degree of medical certainty as to what effect the medication administered to Danny Millett had on Mr. Millett?
I think those medications ended his life, killed him.
Dr. Ely, I'm next going to direct your attention to Brandy McDonald. And showing you State's Exhibit 5, the medical records of Brandy McDonald, did you examine those in the course of your review of this case, Dr. Ely?
Yes, I did.
Based upon that review, did you draw up a report regarding Ms. McDonald?
Yes, I did.
Can you tell us what you found significant regarding Brandy McDonald from her medical records?
Yes, Brandy McDonald was a very unfortunate 37-year-old who had ovarian cancer. So she had ovarian cancer, which we know had already spread throughout her body. And she was undergoing chemotherapy to try and control the spread of this cancer so that she could have as much time with her loved ones as possible. She comes in the hospital with a problem of vomiting and a severe worsening of her liver and kidney from the chemo.
And she entered the hospital on January 11th, 2018.
That's right.
What was significant that occurred on or after January 14th of 2018 in her hospital stay?
She was vomiting. She couldn't keep anything down, and she was found, based upon her blood work, to have a very, very high level of acid in her blood, meaning that she was not getting blood to her vital organs very well. And so this acid was building up, and she got sicker and sicker until, okay, so I'll stop there.
And I note again that we have a DNR CCA status. Again, a do not resuscitate, is that correct?
January the 14th, yes.
What happened after January 14th that you looked at regarding Ms. McDonald?
Later that the family had decided, based upon her wishes and that she not undergo heroic support at that point, but they wanted to let her life take its natural course. And on January the 14th at 5:45, she received 50 mics of fentanyl for a pain score of 8.
In your review of the records, did that appear to relieve her pain at that time?
She still had pain afterwards.
Okay. What happened next?
She was then given 1,000 micrograms of fentanyl,
Any other medication at that time also?
as well as 6 milligrams of midazolam.
And was that again in the process of palliative extubating her?
Yes.
Based upon your review of the records and your expertise, did you draw a conclusion to a reasonable degree of medical certainty what that medication did to Ms. McDonald?
That medication killed her. There's no reason whatsoever to go from 50 to 1,000. Nobody would do that. You'd go from 50 to 100, 50 to 75.
Was there anything else in the records to support giving that large dose of medication to her?
I found nothing, and don't forget that in addition to that, she had already disease from the chemotherapy of her liver and kidneys and other vital organs. So we know that she cannot process that amount of medication. So we have to be sure we cover her suffering, but we have to do it in a way that's within the standard of medical care. 50, 100 micrograms, which can be monitored carefully and then given more over time.
And in looking at the second page of your report on Ms. McDonald, I note you talked about the synergistic effect of opiates and benzodiazepines. What do you mean by that regarding Ms. McDonald's case?
Well, these drugs, when given together, are going to have this additive effect on each other of stopping you from breathing. We do want to reduce suffering, but in this case, she didn't have a need for both the benzo and the pain medicine. I would have just given her some pain medication because that was her main complaint.
And again, based upon your expertise, your review of the medical records, and to a reasonable degree of medical certainty, do you have an opinion as to how those drugs, medications given to her, the fentanyl, the midazolam, affected Ms. McDonald?
I think it prevented her from being able to take a breath.
And would that have killed her?
Yes.
Dr. Ely, did you next look at the medical records of Frances Burke, which is marked as State's Exhibit 6?
Yes, I did.
Based upon your review of Ms. Burke's medical records, did you draw up a report?
Yes, I did.
And based upon your review of the medical records, what did you find significant regarding Frances Burke's medical stay at Mount Carmel West, which began on January 13th, 2018?
This is a 73-year-old woman who came in the hospital with a large bleed inside of her head. It was in the left side of her brain, and she had swelling inside of her head, which was shifting the brain over to some degree, which was very dire. No question. And neurosurgery was consulted, and they didn't think they could fix it.
What else did you find significant?
She had a pain score documented again of 10. I don't know why people are documenting a pain score of 10 when that's not actually a thing. They'd have to put 8. But
Did you look?
the issue was that before that, it was zeros. And so she's got these zeros, and all of a sudden it shifts to 10. And I said earlier, that doesn't make any clinical sense when somebody's already in a coma.
Okay. What about other medication that was prescribed to her prior to the fatal doses?
She was given a reasonable dose of fentanyl, 100 micrograms of fentanyl at 1648, which is fine. There's no problem with that. You can monitor what that does to the person and see how they're able to tolerate that.
Okay. And according to your review of the records, did she tolerate that?
It seems as though she did.
What happened next that was significant in your point of view?
The decision was made to change her code status to DNR, and then she was given at 12:02 1,000 micrograms of fentanyl, and the pain score was again noted to be 10. I don't know how they determined that because she didn't give any evidence grimacing. She had no external signs of pain that I was able to find, and she was then pronounced dead 17 minutes later.
And did you draw a conclusion based upon your experience and your review of those medical records to a reasonable degree of medical certainty as to what happened to Ms. Burke?
Yes, I did.
And what was that, sir?
I think it was unethical to give her that higher dose of fentanyl when she'd already tolerated the earlier lower dose, and there was no evidence of ongoing suffering.
All right. And you talked a little bit about the need for symptomatic management and how this dose could affect a patient like Ms. Burke. Tell us a little bit about that.
I'm sorry, repeat your question?
Sure. Let's focus on how this type of dosage could affect Ms. Burke.
Right, so she's already got this big bleed in her brain. We know that's severe. What we want to allow her life to do is to take its natural dying process, which could be that she could wake up in a couple of days and have some interactions with her loved ones. That can absolutely happen. Even if that doesn't happen, remember that my job is to allow her life to take whatever its natural course is and allow the candle to burn out on its own. But what the medicines did was they blew the candle out, stopped her from breathing, and killed her.
And is that based upon a reasonable degree of medical certainty?
Yes.
I'm next going to direct your attention to Jeremiah Hodge.
Can you lower it down a little bit?
Sure. Give me just a second. And I'm showing you what's been marked as State's Exhibit 7. These are the medical records of Jeremiah Hodge. Did you review these in the course of your drawing up a report regarding Ms. Hodge?
Yes, I did.
All right. And based upon your review of those medical records, did you draw up this report?
Yes, I did.
What did you find significant from those records regarding Ms. Hodge, Dr. Ely?
This is a woman who came into the hospital with a full-on cardiac arrest. She's 57, a young woman, and she has very profound problems in oxygenation and in blood pressure. She is determined to have that her whole heart is not pumping well enough. So essentially she's having a big bad heart attack. And she has reasons to have all this. She has diabetes, she has bad cholesterol, and she has blood pressure problems, hypertension. So this is the natural result of heart disease that's gone bad.
And she entered the hospital on April 1st, 2018 and remained there that entire day. Would that be accurate?
Yes.
At some point she ended up intubated?
Yes, she was having difficulty breathing, so she put on a breathing machine.
And at any point did you note an improvement as far as circulation or consciousness?
She did. Her circulation recovered to some degree. She did not regain consciousness, but her circulation started to stabilize. So what it would make me want to do as a doctor is say, okay, well, she's blood flow is going again. Let's see where this goes. Over the next 24 to 48 hours, family, we don't know. This is scary for you, I know, but let's see how she does over the next 2 days.
During the time period that you looked at the medical records, did you note what her pain score was?
Her pain scores, I can't recall. You can point to me.
I'm going to refer you to number 3, paragraph 3 of your report, doctor.
She wasn't exhibiting pain.
What ultimately ended up happening as far as drugs in conjunction with palliative extubation, sir?
Yeah, there's this seemingly rapid movement within 15 minutes of moving her towards a high dose of fentanyl. 800 micrograms of fentanyl, 6 milligrams of midazolam, and there weren't any pain or anxiety records to document why she would need those medications, especially in those doses.
And in fact, do you note that this was the only pain and anti-anxiety medication she received during her stay at that hospital?
Correct.
All right. Based upon your expertise, your review of the medical records, do you have an opinion to a reasonable degree of medical certainty as to what caused Ms. Hodge's death?
I think the fentanyl and the midazolam caused her death, and if you look at the time of administration and the time of death, there's only 6 minutes between the drug given and the death. So she died 6 minutes after the administration of those medications, and you don't die that quickly when your circulation has regained. Her circulation was back, so I would expect her to keep going. Let's see how she does, but this ended her life.
And you indicate that a patient who presents unresponsive with continuous coding, as the case is here with Ms. Burke, is unable to have a response to pain stimulation. Explain that to us, please.
Well, she would not be able to exhibit pain in that circumstance just because of the degree of medication she was given after getting the medicines. But before that, she was not exhibiting suffering either by the records, by the medical records.
So to a reasonable degree of medical certainty, what would be the purpose of giving her 800 micrograms of fentanyl and 6 milligrams of midazolam?
There's no palliative reason to give those doses of those drugs because she wasn't exhibiting the suffering. So the only thing I could understand would be that you'd be trying to end her life, shorten her life.
All right, next I want to talk to you about James Allen. And I'm showing you what's been marked for identification as State's Exhibit 8, the medical records from Mount Carmel West on James Allen. Did you review those, Dr. Anderson?
Yes, I did.
And based upon your review of those records, did you author a report?
Yes, I did.
What did you find significant about Mr. Allen from those medical records in this case, sir?
He had a severe infection. We call it cholangitis. You know, you have a gallbladder, and there are tubes taking the bile from your gallbladder down into your GI tract, and when those get blocked up by stones, you get this problem of cholangitis. The good news is we can remove the stone and give you antibiotics and usually save your life. So that was the problem that he had. He did undergo a really rapid heart rate during all of this because that happens a lot in sepsis. And when that happened, his blood pressure dropped and he was put on life support.
And he entered the hospital on May 24th of 2018?
Yes.
And remained there until May 28th, 2018 upon his death?
Right.
You note in, and I'm going to, I believe to refer you to, it's number 3, he went into atrial fibrillation with rapid ventricular rate, became hypotensive, experienced dark bloody secretions on suction. Explain that to us so we understand, sir.
A large number of people who get infected like this, their heart starts to quiver to some degree, a little bit in one of the chambers, and that's called atrial fibrillation. It doesn't usually kill you. It's something we can control with heart medicines. There are millions of people in the hospital with atrial fibrillation right now, and all we need to do is slow your heart rate down. So that's not a lethal problem.
What did you note regarding his pain scores and the Glasgow coma scores during the time period, Mr. Allen?
Oh, it was very, very encouraging. His pain scores were all zeros. There were some dashes, but it was very encouraging that he was not in active pain.
And you indicate he remained stable in the ICU and his body accepted the treatment provided up to his death. Explain that to us, please.
He was doing well. I mean, he was improving and stabilizing. His GCS scores were 8. That's not a dense coma. He was opening his eyes, withdrawing. He was grimaces to pain. So this is a person who, very unlike the other patients, was not in a profound end-of-life state.
What ultimately ended up happening with Mr. Allen, Dr. Ely?
What happened was that on the evening of May 28th, his code status was changed to DNR, and he was given 1,000 micrograms of fentanyl, 6 milligrams of midazolam, and that ended his life. In fact, 20 minutes later.
And this was again given in the procedure of palliative extubation?
Yes, but it doesn't meet any of the criteria for palliative extubation. The patient did not have elevated pain scores. He did not appear to be suffering. He was actually tolerating things to the degree that we could let his life go on and have its natural course, but it was ended in 20 minutes by these lethal doses of fentanyl and midazolam.
And based upon a reasonable degree of medical certainty, your expertise, what did those medications do to Mr. Allen?
I think they killed him.
And you go on to talk a little bit about there was no clinical basis to remove Mr. Allen's breathing tube at that time. Explain that to us, please.
I'm sorry, repeat your question?
Sure. You go on to talk about there was no clinical basis to remove Mr. Allen's breathing tube at that time. Explain that to us, please.
Yeah, okay, we haven't discussed this at all yet, so this is a good one. If I have somebody on life support, we can still make you a DNR and leave you on the life support. Just because I don't want to get chest compressions or get shocked doesn't mean that I don't want my full chance at living. So I have lots of patients every day who are on life support that I make DNR, and the agreement I'm making is I will respect your wishes to not go through chest compressions and shocking, and yet I think this life support can get you through to the other side so you can live out your life. And this particular patient is the first one we've gone over yet that really seems a great candidate for that. That I don't think there was any, I don't know why he was taken off the breathing machine.
And going to the second page of that report, you again talk about fentanyl being a high alert medication and how that would affect this patient, Mr. Allen specifically. Can you explain that to us?
Yeah, if you look up fentanyl in drug books under adverse reactions, it doesn't just say respiratory suppression. It also says low blood pressure, cardiac suppression, so it's hitting both. This is not true that the drug is just affecting your breathing. And remember, this person has a global problem with their heart. So 1,000 micrograms of fentanyl is absolutely going to play a high alert situation for somebody with a profound heart problem. And if we want to let his life take its natural course, we need to not give him a medication which poses such a threat to his cardiac function.
Dr. Ely, I want to talk to you next about Troy Allison. And did you review States Exhibit 9, which are the medical records of Troy Allison from Mount Carmel Hospital?
Yes, I did.
And from that, did you draw up a report?
Yes, I did.
What did you find significant about Mr. Allison's stay at Mount Carmel Hospital, which began on July 15th of 2018?
Well, on the 15th of 2018, he came in with he was found unresponsive, decreased responsiveness, and he had a big kidney problem. His kidneys were acutely failing. They measured his kidney function, and he was in outright kidney failure. They did an upper GI to look and figure out what was going on, and one of the things that they found was a swelling of his food pipe, his esophagus. His kidney function, which is referred to there as AKI, which stands for acute kidney injury, his kidney function resolved, and he was discharged home on antibiotics to take care of that swelling of the food pipe. He did have diabetes, so that would puts him at high risk, but he had no history of alcohol or other drug use. And then he comes back to the hospital in the emergency department with respiratory distress, elevated blood sugars, and this kidney insufficiency. And so he gets a CT scan, which is fairly unremarkable, and you want me to stop talking? Is that enough?
No, what else?
Okay. So the supervising physician is looking over him, and they figure out, they project what they should do for him, and he gets further assessments and sent to the ICU because he's not doing very well. And they get a blood gas, which reveals a lot of acid having built up in his blood and a really, really high sugar level. So his diabetes has gone through the roof. And that's totally fixable. We have problems with diabetes of that nature all the time, every day, and we take care of that.
At some point, was he intubated?
Yes.
And during the time he was in the hospital, was any type of pain or agitation noted?
He was not having a lot of agitation and pain. He was, he had, let me catch up here in my thoughts. He was basically, on the life support, not doing well. They were trying to get him back from this big lactic acid level that had built up, and trying to stabilize him, but they were having a difficult time stabilizing. And then he did not have any signs of pain or suffering, but they were still having a lot of trouble getting him stabilized on the life support. And then he was given this dose at 1:25 in the morning of 1,000 micrograms of fentanyl with nothing else, and he died 3 minutes later.
And how much did he receive as far as fentanyl?
1,000 micrograms.
And do you recall whether or not they did have to perform CPR on him at some point?
They had already done CPR on him earlier.
Okay. Based upon the medical records, your review of them, and your expertise in this area, did you reach a conclusion to a reasonable degree of medical certainty regarding that dosage of medication, 1,000 micrograms of fentanyl, and how it affected Mr. Allison?
Yes, I did. I think that this medicine, again, ended his life. I think it caused a death. And what doesn't make sense about it is that if you're having problems from diabetes and you're on life support and we're trying to stabilize you, let's keep going. This is something that we can get you back from. And I need more time. I'm thinking as a doctor, I need more time. I need 6 more hours. I need 12 more hours to get this all under wraps. But instead, we give a lethal dose of fentanyl and stop his life. And it goes counter to anything that I would understand was the goal.
And his kidney injury, how would that affect his ability to assimilate this drug, fentanyl?
That's the other problem, is that you can't process fentanyl when you have kidney failure like this. That's how you get rid of the fentanyl. So it's going to ensure he gets a drug in his body that he can't reduce. And so the full brunt of the fentanyl is going to get there and stay there and keep you from breathing.
Dr. Ely, I next want to direct your attention to Bonnie Austin. And showing you State's Exhibit 10, which are Bonnie Austin's medical records from Mount Carmel. Did you review those in the course of drawing up this report?
Yes.
And from there, you did draw up this report?
Yes.
What did you find significant about Ms. Austin's stay at Mount Carmel West, which began on September 30th, 2018?
She came in unresponsive and was found to have a collapse of her lung. So she was given a chest tube to allow that lung to re-expand. And in evaluating her further, she was found to have pneumonia in both of her lungs. She already had a history of lung disease and high blood pressure and kidney disease. She was, she was very, very sick with pneumonia and was going to be given antibiotics to come back from that. That's the hope at that point. And on the same day that she came in, that night, she was given 600 micrograms of fentanyl, 6 milligrams of midazolam, and she died a mere 21 minutes later.
And prior to
31 minutes later,
receiving
sorry.
that medication, what did you find significant regarding her pain and Glasgow coma score?
She didn't have evidence for giving these high doses of drugs. There was, she was unresponsive. She did not respond to verbal or physical stimuli. So it'd be as though you'd be sitting there looking at somebody in a coma, super sick, with no evidence that they were in pain and suffering, and no need to give much medication. So again, if I wanted to stay just above what suffering might come, I might give 25 or 50 micrograms of fentanyl, but I would never go and give 600 and 6-imidazolame.
And again, this was done in the procedure of palliative extubation?
Well, I don't think that that's justified, but that may be what somebody said that they were doing, but that doesn't make medical sense.
And based upon your expertise, your review of the medical records, and to a reasonable degree of medical certainty, do you have an opinion as to what this level of medication and drugs did to Miss Austin?
I think it killed her.
During her stay at the hospital, did Miss Austin receive any other type of pain medication that you noted?
Not that I saw.
So certainly tolerance would not be an issue with Miss Austin.
She was essentially naive to the medication, so her body had not seen it. It wouldn't have any tolerance built up whatsoever, and that's why she couldn't tolerate maybe even 100, maybe 200 micrograms of fentanyl, much less what she was given. And then on top of that, the synergistic effect of the benzo, which also stops you from breathing.
Dr. Ely, I'd next like to talk to you about James Timmons. In showing you what's been marked for identification of State's Exhibit 11, the medical records of James Timmons from Mount Carmel West, did you review those records?
Yes, I did.
Based upon that review, did you draw a report?
Yes, I did.
And what did you find significant about Mr. Timmons' stay at Mount Carmel West, which began on October 22nd of 2018?
He had essentially a drug overdose. This is a 39-year-old man who came in unconscious, found down. He was given the Narcan, trying to override it, and the toxicology screens were positive for cocaine and cannabis, THC, marijuana. So it was determined that this was the cause of these problems. But when you're down, you can develop damage to your body. And he developed what they thought was a compartment syndrome. So he underwent a procedure to relieve that. It was successful. He was alert and doing okay. He was interacting with his brother after the surgery and no longer reported pain. He was not complaining of pain at that time, although I would have kept him on some low doses of pain medication because he had this surgical procedure. And after the procedure, he dropped his blood pressure, and the attempts at recovering from that were not continued, and a conversation ensued that made people decide that this 39-year-old did not warrant any further care, support, so support was withdrawn. And at 3 a.m., on the day after he was admitted, he was given 1,000 micrograms of fentanyl, 10 milligrams of midazolam, and he died just 13 minutes later.
Now, first off, what is compartment syndrome? Can you explain that to us?
Compartment syndrome is if you get unconscious and lie on the ground too long, your body's own weight will damage part of your muscles. And that's what happened to him. I don't know how long he was down, but he was down too long. And so you might think of like the anterior portion of your calf. If you were on your stomach, lying on your stomach, that anterior portion of your calf, all that muscle would get damaged. And then when we get you up and get you in the hospital, it starts swelling like this. And it's surrounded by a tissue, a very tight connective tissue that only has so much room to move. And so if you feel that it'd be like this water bottle, but now all of a sudden I try and shove 3 times too much water in this, and that's going to get tighter and tighter and tighter. And then when it gets tight like that, no blood can get into that part of your leg. So we call that a compartment syndrome. It's a syndrome where that compartment is too tight now and no blood can get in there. So it actually is a medical emergency, a surgical emergency.
Now, you noted that on October 24th, 2018, at 3 a.m., he received 1,000 micrograms of fentanyl, 10 milligrams of midazolam. Did he receive additional medication shortly after that?
Yes. 5 minutes later, he also received hydromorphone, 10 milligrams, and another 10 milligrams of midazolam.
And how long after that was it before he was pronounced dead, sir?
8 minutes.
Based upon your review of the records, your expertise, do you have an opinion to a reasonable degree of medical certainty as to what caused Mr. Timmons' death?
Yes, the medications that he was given at 3 o'clock and then again at 3:05 caused his death.
Did you also believe, or do you believe, that there was nothing left to do for Mr. Timmons?
There was a lot left to do for Mr. Timmons.
Explain that to us, please, sir.
This was a patient who was suffering from addiction who could go into rehab. He could get his compartment healed up, and he could recover from that and find and live a life of recovery, like thousands, millions of people do all over the world. And I don't understand why he couldn't be given that chance.
Now, because he was a street drug user, how would that affect the idea of opiate tolerance on him?
It would make him, he would have tolerance in his body for sure. He would have built up that tolerance, but we don't develop tolerance so well to fentanyl. And he wouldn't also have tolerance to the benzodiazepine because he probably wasn't taking those. So I told you earlier that cross tolerance from street drugs doesn't work so well for fentanyl. And I don't know that he was chronically taking benzodiazepines. So the double types of narcotics he got and the double doses of benzos, a person can't live through that.
Now, how would the opiate tolerance affect Mr. Timmons if, hypothetically, he received 14,000 micrograms of fentanyl during the surgery for his compartment syndrome?
Well, if you're on a ventilator, on life support, you can tolerate it because we're going to breathe for you anyway. But it still would, we would need more medicine to control his pain, but not anything in that realm. This is so far beyond Thunderdome at that point.
What about the use of midazolam or fentanyl and hydromorphine together in regards to Mr. Timmons?
Those drugs are synergistic. They're going to both work to stop the brain from sending a message to the body to breathe. So you're shutting it down, the ability for the body to breathe.
And to a reasonable degree of medical certainty, what do you believe killed Mr. Timmons?
I think the combination of benzodiazepines and double narcotics that he received stopped him from breathing, stopped his heart from working, and killed him.
All right, I would like to next talk to you about Sandra Castle. Did you review what's marked as State's Exhibit 12, Sandra Castle's medical records from Mount Carmel West in regards to this case? And from that, did you draw up this report?
Yes, I did.
What did you find significant about Ms. Castle from her medical records?
She had a cardiopulmonary arrest at her house. The family witnessed it. They called EMTs. They came, they shocked her, and they eventually got her circulation back. She had recurrent ventricular tachycardia, which is a very life-threatening condition, but they were able to...
Hold on.
Oh, sorry.
You used the syllables about yay long, and she didn't get it down, so she's asking timeout.
Okay.
Do you need him to spell that?
I just didn't understand what he said.
I'll say it again.
Go ahead.
Go ahead.
Ventricular...
I'm sorry, slow down just a little bit.
Okay.
He was trying to, but
Ventricular tachycardia, for which she got defibrillated, meaning shocked, and then she was brought to the hospital.
What else did you find significant? Well, and let me back up. That occurred on November 10th, 2018?
Correct.
Between that date and the date of her death on November 13th, 2018, what else did you find significant about Ms. Castle's stay in the hospital?
When she had that episode at her house, she did have a period of time where she wasn't getting enough oxygen to her brain, and so her brain suffered injury from lack of oxygen. She had a lot of underlying lung diseases. She had emphysema. She had diabetes.
And was she intubated at some point during her stay in the hospital?
Yes, she was.
And when was she actually extubated?
On November the 13th at 4:42 in the afternoon.
And hypothetically, if you were told that she received doses of morphine between that time up until the time she died, would that surprise you?
No, she was trying to be kept comfortable. She wasn't awake, though. She wasn't waking up and responding to her family who were there. So I found the medical records to indicate that she was probably undergoing a comfortable dying process. How long that process takes, I don't know. Could be days and weeks, is what I would tell the family.
What happened after that that you found significant?
Well, on the 13th, in that afternoon, in the evening, she was given 1,000 micrograms of fentanyl, 10 milligrams of morphine, a cocktail that would absolutely lead to death in somebody who was unable to tolerate that. No human being could tolerate that, actually. And she died a matter of 23 minutes later.
Okay, and you said morphine. Did you mean midazolam?
I did. 1,000 micrograms of fentanyl and 10 milligrams of midazolam. Sorry, this combination of narcotics and benzos, once again, both of which stop you from breathing.
Prior to that, her receiving that dose, a few hours earlier, what was noted for her Glasgow coma score?
She was found to be comatose.
Which means what to us?
Well, she's not arousable, not engaging with anyone, and not exhibiting any signs of suffering.
Was Miss Castle still alive at the time she was administered the fentanyl and the midazolam?
Absolutely.
Based upon your review of the medical records and to a reasonable degree of medical certainty, do you have an opinion as to what those levels of drugs, the 1,000 micrograms of fentanyl and the 10 milligrams of midazolam, did to Miss Castle?
Yes, I think that they killed her. The main point being that they weren't used judiciously. She was given a dose that would stop her from breathing.
Now, you talked about you would expect her to get slightly higher levels of morphine throughout the time period. Why is that, sir?
Not necessarily slightly higher. I would expect to be giving her something.
Okay.
She could be getting 2 milligrams of morphine every couple of hours. She could be getting 25 to 50 micrograms of fentanyl every couple of hours. That would be very reasonable to do for a woman like this.
If she were receiving that, would there be any reason to then up it to 1,000 micrograms of fentanyl and 10 milligrams of midazolam for her?
I've never seen that done in 30 years of medicine. It's just completely not done.
And to a reasonable degree of medical certainty, do you have an opinion as to what killed Miss Castle at this time?
The lethal doses of medication she was given took her life.
I'm next going to direct your attention to Miss Rebecca Walls. And I'm pointing your attention to State's Exhibit 13, the medical records from Mount Carmel on Rebecca Walls. Did you review these in the course of writing this report?
Yes, I did.
What did you find significant from Miss Walls' medical records, sir?
She had bladder cancer. This is a woman who had bladder cancer, and she came to the emergency department responsive. She wanted to be evaluated for complaints of nausea and non-bloody vomit. She had belly pain. So at that time, they reviewed her thoroughly, and she did not have a fever. Her heart rate was fine. Her breathing seemed fine. Her oxygen levels were fine. But they thought that based on her x-ray and her physical exam that she had water in her lungs, some swelling in her lungs. So that's a very common problem. We treat that all the time just by giving you fluid pills to get the fluid out of your body, which then leaves your lungs too. So she was giving a very standard course, but with an echo, we were wondering why does she have this fluid in her lungs? And it was found that she had a disease of one of her heart valves, the aortic valve, and that her heart was these valve problems were causing her to build up the water in her lungs. So that's what I found in the chart.
All right, and she was admitted to the hospital on November 13th, 2009, or I think it should be 18. Am I correct? That's just a typographical error?
Yes,
All right, and then until she died on November 19th, 2018?
correct.
Was there anything else regarding her medical stay up until the procedure of palliative withdrawal and extubation was done that you found significant?
She did have some pain, and she was given she was given pain medications. They were giving her to her through an IV, and she was able to tell us how much pain she had. So this is a good situation because we could actually ask her, and she could communicate how much pain she had, which means that I can give a dose, see how it works, give another dose, and increase it if I need to.
And you note that it was done via continuous infusion. What is that to us?
That means that instead of me giving you a shot of the drug every 2 or 3 hours, I'm just going to let the drug dribble in continuously throughout the day.
What happened after that?
Well, at 127, she got 1,000 micrograms of fentanyl and 10 milligrams of midazolam, and she also had the sedatives going through the infusion as well. I don't remember the exact dose of what those were, but these boluses were giving on top of what she was already receiving, and she died 5 minutes later.
And based upon your review of the records, your expertise in the area, do you have an opinion as to a reasonable degree of medical certainty as to what caused Ms. Wells's death?
Yes, I think that the receipt of the fentanyl and the midazolam killed her. She had no sign at that time whatsoever that she was dying. She had a valve problem, which millions of people have. She had some fluid in her lungs, which I can get rid of with a fluid pill. We can take care of these problems. But these medicines stopped her life.
And lastly, Dr. Ely, I'd like to talk to you about Melissa Pennix. And I'm showing you what's been marked for identification of State's Exhibit 14, the Mount Carmel medical records from Melissa Pennix. Did you review those in the course of drawing up this report?
Yes.
What did you find significant from those medical records, sir?
This is an 82-year-old woman. She had a problem with coughing up blood, and it was making her short of breath. She was on several blood thinners. She was on aspirin, Plavix, and Eliquis, which are multiple different types of blood thinners. And she came in coughing up this blood, and on the CT scan, she had evidence throughout both of her lungs of what looks like pneumonia, but if you're coughing up blood, you think this is bleeding in your lungs. So it looks like she was bleeding inside of her chest. She also was having problems with her kidneys, and she had a problem with blood pressure and some anemia already. And the reason she was on those blood thinners was for her heart. So anemia, heart disease, heart failure, given blood thinners, and now the blood thinners they've crossed over from something good for her into something bad for her. We said earlier we want to give medicines that cause goodness, don't cause badness. Now we're out of whack now. The medicines are causing more harm than good. She's bleeding throughout her lungs, and that's what brings her to the hospital.
All right, and her hospital stay started on November 15th, 2018 and ended with her death on November 20th, 2018?
Correct.
What else did you find significant regarding her stay in the hospital, maybe any pain medication she received?
She was put on the breathing machine, and over the course of the 19th and 20th, she was given the right approach to her suffering. She was given some doses of morphine. She had some pain scores monitored. When the pain scores went up to 5, she was given some more morphine. These are all very reasonable things to do. It's what you'd want anyone to do for your mother or your father. Let's keep her pain controlled. Let's see how she does with this bleeding in her lungs. Hopefully that blood can clear out and we can get her on the other side of this. That's the approach that was taken on the 19th and 20th.
And actually on the 20th, she is noted to have a pain score of 9. What did she receive as far as medication to treat that?
She initially received 1 milligram of hydromorphone, which is Dilaudid.
Then what happened when she was palliative extubated later that day on November 20th?
So from those reasonable doses of morphine and Dilaudid, which, as I said, were, 1 milligram of hydromorphone, 15 milligrams of morphine, she was then escalated in a bolus to receive 2,000 micrograms of fentanyl and 10 milligrams of midazolam at 22:49. She was extubated 1 minute earlier, and then she died 4 minutes later.
Based upon your review of the medical records and to a reasonable degree of medical certainty, did you draw a conclusion as to what that medication did to Ms. Pennix?
No doubt that medicine killed her.
Are you done with this record?
I believe so, Your Honor.
Well, it's probably a good time to take lunch.
Your Honor, I think I'm done, so if I can have just a second, I think we can finish it up. And Doctor, just to show you, that was the second page of Ms. Pennix's report.
Yes.
All right, Your Honor, yes, we can break for lunch. I think I'm done, but just in case I think of anything over the lunch, I can finish it off
Okay.
right afterwards.
Ladies and gentlemen of the jury, if we do an hour, would that be okay with you all? Okay, so we get started back at 1 o'clock. Okay, remember the admonition. Have a wonderful lunch, guys.
All rise.
Okay. Doctor, remember the admonition earlier? You're going to do the same thing. We'll see you at 1 o'clock.
Okay, thank you.
Go to the restroom about 12:45.
Yeah.
Ms. Long, sorry. Ms. Sawyer,
Nothing for the record, Your Honor.
Ms. Menashe,
No, Your Honor.
okay?
Just that, Your Honor, I just want to confirm the scheduling, because as I heard the witness say, he didn't have to be in the ICU until next week, and I was told that we were under some kind of time pressure with respect to him only being available today, and I want to make sure that our cross-examination is done in person.
He has a Down syndrome adult brother he needs to be back to take care of tonight, which is why he's only available 1 day.
Yeah, I'm the primary caregiver for my Down syndrome brother-in-law, but in addition to that, I have multiple meetings with patients tomorrow.
Okay. What time is your flight?
I believe it's at 5.
At 5?
I can look and see.
5:59, I believe, so he'd need to be out of here probably 4:45, 5 o'clock. We can get him there. We have a squad car available to rush him.
Oh, it's a swell car.
Okay. We'll do our best.
Okay, thank you.
Okay, we're down for the break.